Going live in 3, 2, 1, and we're live.
Bore da, croeso I gyfarfod bod iechyd Prifysgol Cymru Taf Morgannwg, Hofyn yr Estyn, croeso Canistig Bab, sy'n gwylio heddlu. A very warm welcome to you this morning to our bi-monthly meeting of the Health Board, which is being held, as always, in public. Whilst board members are meeting in person today, we are, of course, broadcasting today's meeting of the board live, which provides an opportunity for friends and colleagues, our partner organisations, and of course the public to observe the meeting today. Can I welcome all those who are observing today's meeting, and of course a copy of the video will be available on the website following this meeting today. Just a couple of housekeeping matters this morning before we start. There are many reports on our agenda today, so for those people who are observing our proceedings, just to say that many of these reports would have been scrutinised by our board committees leading up to today's board meeting, and as a result there is a variety of scrutiny that is afforded to our work, including that which will take place today. We will be taking a very short break during the meeting at around 10 o'clock, maybe 10:15, and possibly again at around 11 o'clock, depending on timings. As usual for board colleagues, just to remind you that questions on the consent agenda were sought in advance of today's meeting, so any questions received would have been responded to. Secondly, just to remind people that as significant scrutiny of board committees would have taken place in respect of many of our reports, please take that into account when focusing on particular areas of those reports. And of course, at the end, as per usual, please give some thought to how we perform today as a board. I think reflection is incredibly important in understanding how we operate as a board, and perhaps bear that in mind as we go through today's meeting and reflect on that once we have concluded. And of course, again, for those presenting reports to board, please bear in mind that colleagues would have read the report, so I'm sure we can focus our efforts bearing that in mind. Can I offer a very warm welcome to Paul Blake, consultant in colorectal and general surgery, who's here to present the listening and learning story this morning. Very good to see you, Paul. It relates to the implementation of robotic surgery, so I'm sure we're really looking forward to hearing about this morning. And also a very warm welcome to Sarah at Wales, who is observing the meeting virtually. Item 1.2, apologies for absence. We've had apologies from Mel Jehu, Councillor Geraint Hopkins, and Nicola Milligan. And if I can just note that James here, Linda Thomas, Ian Wells, and Lisa Curtis-Jones are observing online. So very warm welcome to all of you in physical attendance and those in virtual attendance. Item 1.3, declarations of interest. I've not been notified of any declarations, so if there are any additional matters that people are happy to raise those now. No? Okay, thank you. Item 2, just to remind colleagues around the consent agenda. So just to ensure that we're focusing on the critical matters today. As you know, the consent agenda has been placed towards the end of the agenda today. So if there are any matters that you wish to have brought forward, can you please indicate that now? And we'll ensure that we have a more substantive amount of time set aside for those consent items. No, colleagues are happy to proceed as on the agenda. Okay, thank you very much. Item 3, our shared listening and learning story. I'm really pleased to again welcome and invite Paul Blake to present today's listening and learning story. And before doing so, if I can just say, just to advise those who are observing the meeting today via the live stream broadcast, you won't be able to see the room whilst the presentation is being shared. So just in case it's caused any confusion. And after the presentation, Paul, are you happy for colleagues to ask questions? Yes, please do. Terrific, fantastic. Right, well, delighted to welcome Paul again, and I'll hand over to you for the presentation. Thank you.
Good morning, everybody. Nice to see you all. I know some people, I don't know everybody, but thank you for allowing me the opportunity to put forward the case for robotic surgery here in Cumtock Organic Health Boards. a bit of background, as you said, I'm a consultant rectal surgeon based in Bridgend. I've done all of my training here in South Wales. I spent my last 2 years as a senior registrar in Swansea. And then I went up to Newcastle for just under a year. My main interest is in colorectal and complex rectal cancer cases. So I went to Newcastle to do pelvic examinations where we removed the whole of the pelvis where there's advanced disease. But by very lucky coincidence, they got 3 robots up in Newcastle as well. So I had an excellent basic introduction and grounding in robotic surgery whilst there. And when I came back, I got spoken to by Professor Jared Torkington, leading the case for robotic surgery across Wales. He asked me would I be the clinical lead, and it's an opportunity I jumped at and I tried to run it as smoothly as I could since. And I think we're in a very kind of unique and fortunate position here in Cumtock and Morganic, whereas the Welsh Assembly governments have signed a contract of sorts to procure 4 robots. And in my case, my job then was to try to secure one of those 4 robots for the trust here. And Cardiff and Beta are already up and running, and Betsy Cadwallader have now started as well. And I'm very, very hopeful that we'll be the 3rd trust to follow in their suit. Again, a bit of background, and I've presented this at previous meetings, but here in Cumtock and Morganic, we've got a patient population of 450,000 people. And kind of two aspects I'd like to draw attention to. In the world of colorectal cancer, we've got a national audit where submission of our data is obligatory across the UK and Ireland. It's called NBOCA, and in the year ending April 2021, we have 450 diagnosed colorectal cancers in this trust, which makes it the biggest trust for colorectal cancer across Wales. And of those 450 cases, we operated on 250. And of that 250 major resections, when I speak of the trust, I speak of PCH, POW, and Royal Glamorgan Hospital. And as a slight aside, as a registrar, I worked in all 3 of those hospitals. So I do have an insight into the machinations and the logistics and the people involved in all the different hospitals. So I know how they work, but of all those operations, we were able to do just under 70% of those operations laparoscopic or keyhole, which is of relevance because we have a general rule of thumb that if you can do an operation laparoscopically, you can do it robotically. So we've got a huge patient population that we could potentially operate on and using the robots. So we make up 1/5 of all rectal cancers in Wales and 1/4 of all colonic cancers in Wales, which is a huge prevalence really. And then as part of my registrar training, I did a postgraduate higher degree, and I looked at the correlation between deprivation and the outcomes after major cancer resections. And I did it looking at esophageal and gastric cancer, but the same take-home message is the same. And every postcode in Wales has got a deprivation ranking. It's called the Welsh Index of Multiple Deprivation, and there are 1,600 such postcode rankings. And of the top 10, Cumtock Morganic features 4 times. Penderyn in Merthyr, Tylerstown and Penrhykyber in the Rhondda, and Caerau in Bridgend. So we've got the biggest patient population of colorectal cancers, and we've also got 4 of the most deprived wards in the country as well. And we've also got a significant problem with obesity. I know it's across the country, but in this trust, it is a major problem. And I'll come back to why that's of particular relevance again in a few moments. In colorectal cancer, I've done esophageal cancer, but pancreatic cancer, but I finally settled on colorectal cancer because colorectal cancer is the one where it's the most potentially curative. If you catch a colorectal cancer early enough, or if you can do the correct operation using the correct kit with the correct people, we can cure the vast majority of people. And the management of colorectal cancer has advanced dramatically in the last 20-25 years, whereas in the past, if you had metastases in your liver or in your lung, that was it, you're palliative. Now it's routinely, we'll take the colorectal cancer out, we'll send people to Cardiff, that their liver metastases, or you'll send them to Swansea or to Newcastle, and we'll take out people's vaginas, their uterus, their bladders, their prostate, the lower part of their spine. We can be extremely aggressive given the correct circumstances and would obviously adequate patient consent, but we're constantly trying to advance what we can do. There's going to be no magic bullet or tablet to take to cure colorectal cancer. It's almost like, and again, I alluded to this before, it's like Sir David Brailsford when he was performance director and head coach of British cycling in the 2012 Olympics and subsequent Tour de France, where he had successive wins. he uses the phrase 1% marginal gains, and that's really what we're aiming towards. There's going to be no side that just swipes out colorectal cancer for us. We're just continuously trying to advance on the flanks, and again, with the highest number of colorectal cancers, the most deprived patients, an obese population, we owe it to our patient population to try to do everything we can in their best interests. And my first morning in Prince Charles Hospital 4 or 5 years ago, first morning, first ward round, first 3 people I saw were 3 ladies, all in their early 30s, all young mums, and they all had advanced rectal cancer. I remember that moment I'm thinking, what on earth is going on here? What these are people who have a very, very limited opportunity. They got young children at home, they got partners, they got lives, and it really was a moment of awakening for me. So with all that in mind, when Jared Torkington asked me would I be keen to take this forward, I said absolutely, very, very much so. I'm being very, very honest, and I've tried to be as inclusive as I possibly could. So I sent hundreds of emails to everyone I thought who might have a role to play or be interested, or if we're going to take this forward, if there's any little bumps or issues that need to be addressed, I want to be addressed as early as I could. And we've got a number of the surgical teams involved will be colorectal, gynae, upper GI. I spoke to ENT and neurology, and they have all said absolutely, please run with this. We'll back you, and we've all got a role to play, and they'll all be interested as well. And with that in mind, I organised a roadshow where we brought a robot to the Royal Glamorgan Hospital just before last Christmas. They brought a robot, the consoles, they brought the whole paraphernalia, they brought a whole team with them, and it was incredible. It really created a buzz about the building, and we were using the virtual reality headsets, and it was a really enjoyable day. Loads of nursing staff, theatre staff, they all came along and said, please continue with this. And a couple of things I took away from the day was there was no insurmountable blocks to having a robot here, and if we do get a robot, it'll be based here in the Royal Glamorgan Hospital. And no one said there was no reason we couldn't bring a robot here, and there was no infrastructure changes that were needed. So as I said, the teams involved with colorectal, gynae, upper GI, and urology and ENT. And I will come to the advantage of the robot in a moment, but from a colorectal point of view, we got 4 consultants who are very, very keen to go. And we will plan to do, if we have the robot, we'll do 2 full days with the robot a week. Gynae are very, very keen. Gynae wants to have a full day. Upper GI will want to have a day, and in between us, we would split the 5th day. But there's absolutely no shortage of interest or patients who would really benefit from the robots. And the advantages of the robot, it'll benefit the patients, but it's also a significant benefit for surgeons. And I know that sounds quite self-fulfilling, but I will come back to that why, and especially for the health board as well. So we're going to go into the nitty-gritty of the robot. When you see the robot for the first couple of times, the visual acuity and the accuracy and the precision you can see with the robot, it's incredible. It's fascinating the first few times you see it, and if you walk into a room to see it. And I actually asked for a robot to be present here today. And the company said, you've got no idea how much it cost the first time round. It wasn't tens of thousands of pounds, and I said, no chance. Well, I've got a couple of video clips for later, but they said there's no way we can do that. But from a robotic point of view, the robot as well, it works particularly well with spherical structured organs and with cylindrical organs. Because the spherical structure would be the ovaries, would be the uterus and gallbladders, and from a cylindrical would be the rectum. And we're pretty well trained, and certainly not blowing around trumpets, but we're well trained in South Wales, especially from a colorectal point of view, and Swansea particularly is a major tertiary centre where people come from all over the world to do their fellowships. I spent 2.5 years. We get a very good grounding there, so we can do the operations, the vast majority, and we'll get the cancers out. But a big part of the operation is the avoidance of any collateral damage, and next year particularly relevant for us is the pelvic nerves. So we'll get the rectal cancer out vast majority of times. And part of the reason I alluded to those 3 young ladies a little while ago was in the last 15-20 years there's been a second peak of colorectal cancer across the world. We don't know entirely why. It used to be a disease of people in their 70s and their 80s, but now there's this peak of people in their 30s and 40s getting colorectal cancer and rectal cancer. So we don't know exactly why. These are people who will get the cancer, but they still got 30, 40 years of living to do. And as part of that, operation preserving the nerves, and a lot of these people have a radiotherapy as well, and their nerves will be damaged. We need to secure the pelvic nerves, A, because it controls their urinary function, and we do not want to render young people in their 30s and 40s incontinent, but it also, they're the nerves that control sexual function. So for males, it'll be ejaculation, impotence, and for females, it'll be ability to get pregnant and to maintain a pregnancy. So this has got a huge kind of psychological impact on these people and well-being, and that's why I kind of alluded to those three ladies a little while ago. So there are three young ladies with families, and they had, we'll get their cancer out, but they've still got another 40, 50 years of living to do. And purely from a financial point of view, these are people going to depend on the NHS for the rest of their lives, be it for the management of their incontinence, for fertility treatment, for IVF treatment, from a psychological point of view. Other points from a colorectal point of view as well, it's the blood loss. We can see every little drop of blood that's shed. We see it laparoscopically, but with the robotic, we can preempt it much better. And as we'll get the cancer out, but it's the blood loss. And when we're deep down in a pelvis, in a morbidly obese patient, they've had radiotherapy, so everything is very, yeah, this is almost more terrifying than an operating room like that. And these are the kind of problems then that cause patients to go to ITU if we have a massive blood loss or they lose a significant amount of blood in an operation. And before I presented previous time, I did a quick Google search, and an ITU bed in the UK currently costs just over £1,600, whereas a normal ward bed is £450. So every time we can save a patient a 24-hour period in ITU, that's in excess of £1,000 saving. And can I go back when I spoke to the gynecology surgeons about a big part of their problem is hysterectomy. So they do about 15, 20 hysterectomies a week in the trust, but a huge percentage of their patients are morbidly obese, which automatically means they're not amenable to laparoscopic surgery. They have to be open surgery, which is a C-section scar down at the lower part of their abdomen. The problem with that is, again, they'll get the uterus out to do the operation. It's the sequelae afterwards. These are people who are morbidly obese. These are wounds that are extremely prone to infections. Once you get a wound infection down in that part of the body, there are people then who get hernias. And hernias are a big problem in the NHS from a surgical perspective. They're a poor relation in our list of priorities. We'll deal with emergencies, we deal with cancers, we deal with vast majority of other things. But hernias are something that no one really wants to take on because they're difficult. They've got a high recurrence rate. They're expensive. They involve mesh. And we always tell the patients there's absolutely no chance we can 100% guarantee you that this isn't going to come back. So they're a very expensive problem. And the gynecologists are having that problem. So my point was that they can't do these hysterectomies laparoscopically. They have to do them open, but they can do with a robot, and that would increase the number of hysterectomies that they could do with minimal access surgery substantially within a couple of months. Once they're up and running, they'll be able to do this. Another part of the gynecology case is endometriosis, and from what I understand, there's 1 in 10 young ladies in South Wales suffer from endometriosis. That being, you already know, when you get tissue that normally lines the inside of the uterus goes outside the uterus, and this is extremely friable tissue. It bleeds easily, it causes scarring. So again, for these ladies, they got problems with conceiving, with maintaining a pregnancy, with recurrent pregnancies, and part of the treatment to cure the endometriosis again causes these problems with the robotics. Robotic surgery is known to have a much higher success rate, and it's less invasive, it's less damaging to cure these people of their endometriosis as well. I could talk about less hospital stay and post-operative pain, but I think that's already in the business case. The benefits to the surgeons, well, there's open surgery. We can spend hours, and we can spend 6, 10, 12 hours stooped over patients, and when you're operating, you've got a complete tunnel vision. There could be a herd of elephants doing river dance in the corner. You can completely oblivious to it. It just never crosses your mind. All you see is what's right in front, and if you're spindly, which we do. And in my time in Swansea, it was 2 of the colorectal consultants and 1 of the bariatric consultants repeatedly off because of back pain and wrist injuries. And then it really hit home in my time in Newcastle. 2 of the senior consultants that just had spinal surgery, and the consultant who's overseeing my fellowship had to go for an emergency neck decompression surgery whilst I was there in the middle of a week. There's the 6 people that I've worked with and know it who've all had to take time off, and it's got major ramifications for the surgeon themselves. It's 6 people who've had surgery, time off work, loss of operating skills. From the trust point of view, then there's patients who they can't operate on. and they've got to be delegated out to other surgeons, and they might find that the surgeon that just delegate out to is also off with back pain. So waiting lists grow, people don't have their operations. And then from a registrar point of view, the senior registrars aren't getting the training and the time with senior consultants, because these are all senior consultants, and senior consultants who they would have expected to spend their time with are all off sick. So it's got significant ergonomic benefits from, I know that's quite self-serving, but it's definitely a significant factor in the push for robotic surgery. And then lastly, for the health board itself, in terms of reputation or retention, recruitment, prestige, it's got huge implications for the trust. You've got two senior colorectal registrars at the moment in Princess Wales, and they ask me every second day, what's happening with the robot? Will you be getting the robot? And again, I want to kind of keep this whole, like the dragon's dead, I want to keep the whole pitch positive and not be negative in any way. But if we weren't to secure the robots, major questions will be asked of us, and we will be seen as a pariah health board. Will be known as a health board that was being offered a robot and decided not to take it, and people will vote with their feet. I know that they just won't come. So we won't recruit. We won't get trainees coming. It's a trust. We've already had problems with recruiting, and I think it's pretty common knowledge what's happening up in Prince Charles at the moment. There are 3 senior colorectal consultants. Mr. Joseph is retired. Prof. Ray had his retirement party last week, and Mr. Masood will be retiring for him. So that's 3 unfilled colorectal posts that we really need to secure. We're desperate to get people in post for that. So people won't come to us. People will leave. In terms of research, we'll be the first country as such will get all the same robotic systems. So it'll be a huge source of the amount of data we'll be accumulating is incredible. And Hugh Davis is one of the senior consultant nieces here. And very outset, he's been emailing me saying, if this happens, I want to know about this, because I will get senior anaesthetic registrars to come to me. And the numbers, I think what they specifically want to look at is intraoperative analgesics and muscle relaxants they need to give, and post-operative pain that they can manage and avoid people being on opiates and long-term opiates. So it's got huge significance in terms of retention. And then lastly, it will also have knock-on effect on the emergency general surgery cover we provide, because if consultants are leaving to go elsewhere because there's a robot elsewhere, so we will have a problem of leaving, but then we won't have people coming in. So the unscheduled emergency, it'll have significant repercussions now as well, because we won't have colleagues who are forward-thinking, well-trained, dynamic, suitably skilled coming to the emergency operating, because the elective operating is our bread and butter. It's what we and that we see the CTs, we know exactly what we're doing. So it's a step-by-step. Whereas the emergency operating is the immediate through the front door. It's a life-threatening, it's a limb-threatening. It's where all of our basic training comes into play. And those we won't have the skills, senior clinicians to come and do that. What will happen then is if they don't come, we'll end up doing more and more emergency surgery, that we won't be able to do the elective, and then we'll run into a whole other economic problem. So finally, on the Trust website, there's a commitment to listen, to learn, and to improve. And I think we've got to listen to the. I know I'm repeating myself on this one because I quite like them. So we've got to listen. There's an overwhelming body of evidence now supporting robotic surgery. I appreciate it's expensive. I'm fully aware of that. But we won't recoup those losses immediately, but in the long term we absolutely will, and to the infinity, well not to infinity, but multiply to whatever factor you choose for all the reasons I gave above. We've got to learn from our colleagues in Cardiff, in North Wales, in England, France, Ireland. It's not as if we're not leading the cavalry charge. We're not doing anything that's groundbreaking or experimental. If anything, we're just keeping up with the herd, really. And as I said, we've made a written commitment to improve our service to our patients. And as I said, highest number of cases, poorest people, more obesity, more and more rectal cancers. I think we owe it to our patient population.
Thank you, Paul. Just to remind, before I bring Geth in, just to remind colleagues that following this meeting of the public board, we do have an in-committee board session, and we will be discussing a business case for robotic surgery. The reason that is being held in private is because of commercial sensitivity, and that's a very solid and sound reason for doing so. And I understand the video clips will be available in the in-committee session later on when the board considers the business case. So get it.
Thank you, and thanks, Paul. I suppose I just wanted to set an element of context for board members. So, as you've heard, we have, you know, some of the highest rates of colorectal cancer in Wales. We undertake, you know, we are the biggest colorectal unit as CTM across Wales in terms of the operating we do. I think what's really important is to understand where this fits within the jigsaw that is no UHB services. So the first really important developments have been around diagnosis, and we've got the bowel screening programme in Wales, and that's very positive. The age of that is changing to increase catchment, and will ensure that with greater level of our population are routinely undertaking testing to enable them to identify colorectal cancer early, because clearly the earlier we catch it, the smaller the tumour, the greater the success of surgery, and a reduction in associated morbidity to patients. So that's really important. We also have now implemented across Wales FIT testing for symptomatic cases, which allow us to screen patients to the most appropriate diagnostic test as soon as they've had those first sign of symptoms. So we're using that to really try and ensure that those patients who are at greater risk of having a colorectal cancer can be moved through the pathway as quickly as possible, and that becomes a really crucial part, because time is important in these pathways. Linked to that then is endoscopic investigation, and crucial to this is colonoscopy, and a big part of what we're doing around planned care recovery is increasing our capacity for colonoscopy, both within what resource we have now, but also people are aware the potential development of the Llantryston Health Park is to really expand colonoscopy capacity for us as a health board, so that we can move patients through in a speedier way. And associated with that, and the work that the team in radiology have done to provide CT scans within a very short period after a colonoscopy, so that again that diagnostic pathway is kept as short as it can. We know, and you know from performance discussions, that's a challenge for us at the moment, the lower GI pathway, and all of these bits of the jigsaw are about trying to create the right service for our population so they can get the best outcome. And this bit is then the final bit in the jigsaw. So as Paul's alluded to, at the moment we provide resective surgery on all 3 sites, and that's a challenge. Sustaining that capacity, sustaining the number of surgeons required is a challenge. If you look at Cardiff, they do all their colorectal operating in 1 unit. And part of this is about allowing us to bring together some of those more complicated cases using cutting-edge technology, and that's a really important part of this, is about trying to ensure our patients benefit from the technologies that are out there and they're not disadvantaged. And part of that means that we will need to single site some services, and the robot is a crucial part of that. But actually that develops the MDT and allows us to move that forward. So I think the other bit just to stress, and I've been overwhelmed by actually, is the utter enthusiasm from the colorectal team to really operate as a single service. So we, the conversations that are going on across the board with colorectal, and I was fortunate to have a meeting with the whole colorectal MDT across all 3 sites a couple of weeks ago. The commitment to working as a single service for the benefit of our population is absolutely paramount, and this is a really important part of that jigsaw.
Yeah, thank you, Jeff. You picked up a couple of my points, so I won't go over them again. But I think it's Paul. Yeah, thank you first of all. Thank you. Just all, very passionate, very eloquently sort of stated what the points are, and representing actually the views of all our surgeons. And so from my point of view, it's the quality impact for our population, and what this is basically doing is saying we're bringing it up to parity with what actually is the expected standard. So it's nothing new. It's nothing new. It's nothing groundbreaking, I think is your exact words, but it's just something that our patients will benefit from, both physical and psychological, and as well as showing that we're supporting our staff as well, and keeping our staff actually being able to operate. So thank you very much.
We have to do it because in this end booklet, it's all now a key quality indicator. So it's a part and parcel of the normal operating elsewhere.
Linda Thomas and then Ian Wells. Linda?
Hi, Jonathan. I put a note saying I've got a question to ask, but I'd probably like to ask it in the committee session rather than this session, if that's okay.
Yeah, that's no problem at all. Thank you very
Thank
much.
you.
Thanks. Ian?
Yeah, I said the same as well. Sorry, I misinterpreted what I wrote. Apologies.
Okay, no problem. Thanks. Paul?
Yeah, I mean, look, I'm really supportive, and absolutely needs to be something we look at, you know, that as you described, Paul, the challenges for our population necessitate this sort of approach, because we need to be able to provide the best outcomes for our communities, and we know that our outcomes in terms of cancer care across the board are not where they need to be in this community. I guess you described really eloquently there the pathway out of which this is the most sort of acute end in terms of the sharpest bit of the journey, isn't it? But I guess, what Philip's saying, but the other bit I'm really interested in is how do we get upstream and tackle it? I mean, because there is rightly a focus on the treatment end of this now, which is where we need to be. So when people need a treatment, we've got to make sure they get the right treatment as quickly as possible and the most high spec treatment they can have that will get the best outcome when they need it. But I guess, you know, you described really well also, Paul, the demographic challenge we have in this community of prevalence. And I guess there's something, and I know we do the screening, but Philip, I guess there's something here about how, with our focus on population health and public health, I'm just thinking, how do we use potentially today's decision, obviously, the potential acquisition of a robot as a bit of a catalyst for a conversation with the population about the topic of this in this wider sense, to say to the population, look, we're developing these treatments and we're going to have a fantastic opportunity to provide better treatment for you. But we also need to have a conversation in this community about why are we having such high prevalence rate, and some of it is lifestyle related. Yeah. And so using this as a bit of a catalyst for. I was just wondering, Philip.
I think Paul, you had fantastic presentations. Then I think Gethin indicated the efforts that are going on with regards to the diagnostics, and obviously the earlier you catch it, the more responsive it is to treatment. Yeah. In terms of the screening. I'll work backwards. In terms of the screening, in Kentucky, we can be proud of the fact we've got higher uptake within Wales. And there is a difference between the least deprived and the most deprived communities as well. We need to close that gap, definitely. But we have got things in place. So there's agreement from all GPs to follow up non-responders. And that's going forward. A key thing that we've got that we can be proud of in Kentucky Morgannwg is the effort that's going on in schools around moon dance, and they in Ponty High School, for example, they've used bowel cancer as the focus for their whole curriculum, and so they've integrated it into their whole curriculum, and using that to the pupils will go home to their parents and their grandparents, etc., and push it that way. In terms of the primary and secondary prevention, I'll start with secondary. Obviously, we've got the weight management pathway that is in place now for adults. We're looking at the business case for children. We're also implementing a 7-day alcohol service as well, because obviously alcohol and bowel cancer is inextricably linked. And we're developing a whole system approach to weight management, which is going to be critical, because this will empty the bath to a certain extent, but we really need to turn off the tap as well. And this is about that primary prevention, how we can instill those healthy behaviours and give people the opportunity to take up those healthy behaviours as well. So there is a lot of work that's going on across the system, and we need to look at it from that pathway approach.
Yeah, thank you. Thanks, Philip. And I know that colleagues are looking forward to returning to this matter a bit later today. So obviously some like smoke. Not literally. I mean, what's happening around the world. Thank you, Paul. Really good to see you, and thank you very much indeed for the presentation this morning. And thanks for joining us.
Shall I leave, or do you want to say what?
You're free to leave. It's going to be a long meeting until we get to that one. Thank you very much for your time. Thanks very much. All the best. Thank you. Thanks.
Thank you all.
Thank you. Moving on to item 4 and item 4.1, the chair's report and the Britain Collins seal. My report is attached. There's two things I wanted to say very, very briefly. I touched very quickly on the 75th anniversary of the National Health Service, because that is something that we have acknowledged and celebrated within the past few weeks. There is, however, as you will know, a huge ambition and an appetite for us to think about the services we provide, how we provide them, and where we provide them. And this meeting today will be touching on some of that as we look at the work around the development of the clinical services plan that Linda and Gethin and others will be touching on later on in our meeting. This is about setting the ambition for the future and about having not just hope and aspiration, but be really focused on what it is that we do as a health board, what is it we do with our partners and colleagues, and how we can reimagine the NHS for the future. The last 75 years has been absolutely astonishing. If you chart the creation of the NHS in 1948 to where we are now, nobody would have seen the current picture. All the advances in technology, in medicine, in population health, really quite remarkable. But to sustain a service of this nature for the next 10, 20, 50, maybe even the next 75 years requires huge imagination and appetite. And I know we've got that around this table. So I'm looking forward to the start of that conversation around the clinical services plan later today. In this context, I want to place on public record my congratulations to all of those nurses who were nominated and to those who won in 5 categories in the Royal College of Nursing Wales Nurse of the Year Awards at the end of June. An absolutely fantastic achievement by our nursing staff, and one of whom winning the Chief Nursing Officer for Wales Award. Fantastic result. It demonstrates what our staff do. I think it's right that we articulate and celebrate the contribution of all our staff, and it was a real privilege to attend the award ceremony with Greg and a number of our colleagues who attended the event at the end of June. I'm looking forward to welcoming those who were nominated, not just those who won, but those who were nominated to our board development session in August. And I've written out to them, inviting them to along so we can thank them in person. But I think a fantastic result. It was picked up by many other health board chairs and by senior colleagues in Welsh Government that Cwmtawd Morgannwg staff had done so well. So brilliant news, and I was absolutely delighted. Just to confirm for the record, and although I will be referring to this a little later, as colleagues know, we have 2 vacancies which we have advertised, our Vice Chair's role, but also our IM legal role. The SIFT for both of those vacancies took place this week, and we will be on course to interviewing candidates within the first week of September. So just to confirm, that process is now actioned and on target thus far, which is great. But I should be referring to that matter a little bit towards the end of the meeting. Other than that, just to confirm, there were a number of matters requiring the use of the common seal and my signature. I walked into the office one morning and found a pile of paperwork a mile high. I thought someone had been having a clear out of the desk, and I was informed that it all required my signature. So there are a number of things on there for which the common seal has been applied since we last met. Unless there are any matters that people want to raise in respect of my report, I just ask that the board note it, and in doing so, can ask that the board endorse the affixing of the common seal. Yes. So Simon, yes. Sorry. I was rushing through noting to endorse.
I know. Just going back to your first point about the NHS 75th anniversary. I hope colleagues had the opportunity to see some of the coverage that we garnered around the anniversary. So our health board was the primary focus for the BBC. So we did a lot of work with the BBC. So they broadcast live from RGH and from other parts of the health board as well throughout the day and in the days prior to and immediately after the anniversary itself as well. And just to say, we used that opportunity to celebrate the fact that we were marking this milestone, and and how proud our staff were to be working for the NHS, but also an opportunity to talk about the challenges that we were facing across the whole range of services, from primary care right up to kind of the sharp end of acute services as well. So that was all part of this kind of approach to start planting the seeds about the necessity to talk about change, and for us as a health board to then start making some change as well in the future as well. So just want to mention.
Thank you, Simon. And yeah, if we could pass up all our thanks to those members of staff who were willing to speak to the media, particularly those doing TV broadcasts and radio. It was fantastic to see colleagues leading the charge in demonstrating what value they bring and their colleagues bring to our services. But no, thank you very much. Thanks, appreciate that. Are colleagues happy to endorse the fixed income seal? Yes, thank you very much. Moving on to item 4.1.1, the action log. There are a couple of matters that are still in progress and therefore still open. If I could just point to one area where a decision was taken to refer some matters to the Quality and Safety Committee since we last met, and that was in relation to the report on crude mortality data. We felt it was appropriate for the Quality and Safety Committee spend some time examining that matter before returning to board, and there are a couple of things that are in progress. Does anyone have anything to say on those matters that are the progress carried?
Just to say, we met on Tuesday as a Quality and Safety Committee, and we did discuss that item in detail, and were assured by the actions that were being taken to look at that data. So I think there was a very good follow-up to that.
Thank you, Karen, much appreciated. Dom, you?
I'm happy to give a brief summary of what that is here, or if you'd like to leave that. So we're planning on doing it in the NIM board session in the future, so that might be more appropriate to go into detail.
Yeah, that's fine. Thank you, much appreciated. Anything else on the action log? Colleagues happy to just unnote it? Yep, thank you very much. Item 4.2, the Chief Exec's report. Paul.
Thanks, Chair. So a couple of points from my report to draw colleagues' attention to. Escalation, obviously, as you'll know, still in an escalated state for maternity, quality governance and performance at TI and enhanced monitoring, planning and finance. The tripartite meeting happened a couple of weeks ago, and we're still just waiting. Advice has been given apparently, which is going to the minister. We're just waiting for formal feedback on what that advice has said. So we will hopefully have some clarity on that in coming days with formal feedback from Welsh Government about that. So we will obviously share that as soon as we hear any feedback from that Welsh Government colleagues. We're going to talk about the financial position later on, and we'll touch on the updated position since the reports have been written. Also, just to say, positive news on the transition health part was that we have received the capital funds requested from Welsh Government for this year to support the project team being established for transition health park. We had a programme board yesterday. Linda, Linda Thomas is the IM, who's the link IM now to that programme board. Really encouraging to see that we've now appointed Arcus as our external advisors to the project for this next phase. They are already getting on with the next phase of the planning, so things like applying to the Council Planning Commission, and also the beginning to scope out the master planning exercise that will need to be done to work out exactly what goes where on that site, with a view that we're also trying to plan for some temporary diagnostic capacity to be available on that site, hopefully towards the end of this financial year, all being well, depending on sort of electrical supply issues and all that sort of thing. We're in having conversations with Cardiff about the potential loan of an MRI scanner that they have, a mobile MRI scanner, so that we're looking, for example, to be able to site that there potentially at the end of this financial year. Really positive though to hear that it felt yesterday's meeting felt that suddenly things are really starting to move now on this, and we will start to see activity being ever more happening. All noting also that we are still in commercial negotiations with BA about exit from the site, and there's conversations going on around that as well. So, but really positive, and I think also ever increasing conversations with our neighbours in Cardiff and Anara and Bevan about how the regional service models that are being looked at for orthopaedics, diagnostics and other services could be deployed to the Transition Health Park. So really positive development there. Other positive news I just wanted to highlight was the situation with T Clydiard. Board members will know T Clydiard has had some challenges in the past few years, which resulted in a WISC escalating, so that's level 4 escalation. That was downgraded to level 3 in January and further de-escalated positively at the end of June. So we're now at a low level of escalation, a lower level of escalation. Obviously, our ambition is to get back to routine monitoring and be no escalation. But it's really positive to see the improvement that's happened at QDR, which has been really hard work from a lot of people over a sustained period of time, and not just the nursing workforce, but it's the whole medical nursing, therapy, support staff workforce there who have really worked hard to put in place an improvement in the quality of care provision at that unit. And again, really positive to know. Well, and thanks to Lauren as well, who's taken the exec lead for overseeing the work on the particular VR, because it's not just about improving the care and support for those individuals, but reputationally, it's also about making sure that that unit, which I think it's fair to say had quite a challenging reputation externally for a long time, I think it's really positive to see now the recognition from external bodies of the improved performance and quality improvement there. And I think what's really encouraging also is that it's not like people are seeing it as a fixed point, we just got to get to that point, and then it's that whole process of continuing looking at improving services model there. So really good news there on QDR. And finally, the only other thing to say was that we are just about to start the consultation process for the next phase of the operating model changes. You'll know that we've changed to a care group structure at the end of last year. We had a meeting on Monday this week with the execs where we've reviewed with the care groups all of their structures for the next phase, and there were a few tweaks and changes to make to that structure, but that we will be aiming to start the consultation process in the next couple of weeks or so, which will then obviously move us into the next phase of that change process. Clearly, there are a large number of staff that are impacted and will be affected by that change, and will be obviously following the OCP process. But I think we felt it was important to get on with that now whilst we're in the summer months still, because we want to be in place by the autumn into winter that those changes have been made. But it was really positive to see the care groups plans around that and the thinking that's been done, not just within individual care groups, but across care groups about making sure that things are being done in a consistent way. And so that will be happening next. So that's all I wanted to say.
Thank you, Paul. Jane, and then Dennis. Yeah.
Thank you. Just 2 points. The progress on the health park is really encouraging. And what I found interesting is that in talking to potential consultant applicants, it's already something that they want to talk to us about, and how can they help shape what goes on. It shows the power of this sort of transformation of our services in drawing resources to us. So I think that's an important thing to note. And I also wanted to echo what you said about TQD, Paul, and having visited it over quite a number of years. The place feels different, it looks different, but also the numbers show it's different in terms of the type of care and the way care is administered in cooperation with the young people. It's really good. And I want to also to thank Lauren for the leadership in that area.
Thanks, Jane. I'm just thinking about, it probably would be good, Lauren, to think about perhaps a future board development session to get the team to come and talk about the work that's been done there, because it is impressive. And in such a large organisation like ours, all these things are all going on a daily basis, and it's so easy to sort of say, oh, that's great, move on to the next. But the work that's gone in at TQD is just immense. So
Funny you should say that, Paul, they're coming in September.
oh, that's fine.
If I could just come back very briefly and then have another bite at the cherry. The improvement there is amazing. We had the first conference of ICTM
yes,
a week or so ago.
Yes.
And you're absolutely right about the improvement that is going on across the organisation that we somehow have to surface more widely. There's a lot of talent in this organisation.
Yes.
I think everybody else has said what I was going to say. It was about Lydiard as the Quality and Safety Committee representative on the WISC's Quality and Safety Committee. I've certainly seen the way that things have changed and how we are being viewed by the external organisations, and I just like to congratulate everybody on the work that's gone in to improving that service.
Any other questions to Paul? No, and Paul therefore resolves to note the Secretary report. Thank you very much. Item 5 and item 5.1 under delivering our plan is the first part of the integrated performance dashboard, and just want to advise members, we're going to ask Linda to lead the item and then ask other exec leads to deal with the operation quality, people and culture sections, if that's okay. We divided the whole thing into two parts, and the second part, which is around finance, we'll come back to after our break. So Linda, thank you, over to you.
Thank you, Chair. So in introducing this report, there's a couple of things that I do need to say about it, which is that this is the first time that we have set the targets against the new NHS Wales performance framework for 23-24. They're obviously new ones issued every year. So the performance report has been adjusted against the new indicators. I have requested a report that explains the differences, because I don't think we can really see that, and I think it would lose that that thread of consistency. So that has been requested but not received. When I get it, I'll be able to share that, and you can be clearer about what's changed. One thing that has changed is that stroke has dropped out of the reporting requirement, which is something which I suspect we're not going to be comfortable with going forward. So I have requested that of our team that from September we put stroke back in. It didn't occur to me that something as significant as that was going to come out. So as we go through the report, Lauren can say a bit about stroke, but sadly don't have the figures in front of you, which we're sorry about that, but we'll fix that. So in terms of the report then, who am I handing over to first? Is it Gethin or?
Yeah.
Yeah, thanks.
Thank you, Chair, and I will do a very brief summary because I'm very conscious that this is being discussed and debated at length through Planning, Performance and Finance Committee. So as Paul mentioned, we remain in targeted intervention on a range of key performance areas: planned care, urgent care, cancer, and CAMS. And I'll go in reverse order. So you will see in the report that the CAMS activity in May was significantly up and was the highest level of CAMS activity we've done for some time. And certainly the data now that's showing performance for June is seeing a significant improvement on those levels. So as you'll see in the report, our CAMS performance in May was sitting at a slightly lower position. So we were just at around the 30% mark for part 1A, with that attending increase in activity. I can confirm that for June our compliance has more than doubled to 64%. So we have seen a significant improvement in performance, and the data for July suggests that performance again has continued to improve. For stage 1B, we've now got that performance up to 50%, and for stage 2, which is around the intervention, the target is 80%, and actually for June we were at 88%. So we are seeing a significant improvement in CAMS performance, and sustaining that. So our children can get access to those services in a very timely way is crucial, but significant focus from the mental health care department. In terms of urgent care, you'll note from the report that we've sustained improvements in our ambulance handovers. Our ambulance handovers for May were the second best in Wales. And again, that level of improved performance is continuing. There are variations, as you would anticipate, on a day-by-day basis, but overall, and associated with that has been an improvement in our 4-hour performance and a reduction in the number of patients waiting 12 hours for, in our emergency department, which again is important. But regrettably, we're not seeing a correspondence improvement in response time, despite the fact that we have significantly reduced the lost hours on our forecourts for ambulances. So there's ongoing work with WASP to understand how we can ensure that a more timely response. And equally, whenever there is, we've had no declines of red releases now since January. And in fact, we've only had 2 declines of an amber release request since in that period as well. So it's not that we're not releasing ambulances. Clearly, we want to be able to send them all around within 15 minutes, but we're not seeing that with that increased hours on the road, that corresponding increase in red performance. In terms of planned care, so our reduction in our longest waiting patients continues to improve. And you'll see that the figure for June was just over 4,200 patients. That figure has dropped further now as we head into July, and our position in the league table, I guess, of longest waiters has improved. So at the moment, our predicted month-end position for July will position us just behind Howell Bar and Iron Bevan. So again, when we did have some of the largest volumes of longest waiting patients. So, significant thanks to all the clinical services for the efforts they're making to our longest waiting patients, and how they're using our capacity to deliver that. In terms of cancer, so our cancer performance has stabilised, which is positive. The key areas of focus now is improving on 3 tumour sites. So the first would be lower GI, so colorectal cancer, and as we've discussed, there are a number of aspects that we're putting in. We will be signing we've got a contract review meeting today to award tender for additional insourcing capacity for endoscopy. And part of that will be to increase the colonoscopy capacity for bowel screening Wales patients. There are real restrictions on accreditation for people that can undertake those scopes, and that's a real important area of focus for us. Gynecology, as you know, we've opened the Women's Hub at the Royal Glamorgan. That at the moment is being utilised for patients from the RGH and PCH catchments. During the next couple of months, all our suspected cancers for gynecology will be managed through there, and again will be a significant step up in capacity for gynecology. And urology is the other area of focus with very high volumes and a very complex diagnostic pathway. So a lot of work. That the position in urology is improving, but it is a complex pathway, and it's a complex pathway across Wales. So again, they remain an area of focus. But I'll finish there and have to.
Thanks. Would it be easier if we went through the executive boards first, and we'll put the questions right at the end? Just in terms of some of those matters in relation to operational performance, I'm just wondering, Greg and Dom, do you want to come in? Yeah, Greg, can you come?
I'm happy to just build on Linda's point. We've still not been told of the national quality and safety metrics that are being devised as part of the implementation of the Quality Act. So there's been a bit of a scaled down version in this report today. We probably need to include the PTR stuff in here, I think, for September. That said, we had a good wash through quality and safety on Tuesday in relation to the quality and safety dashboard. Just one thing probably to pick up in here, and that's on page 24. That's the IP&C metrics. We're still waiting for Welsh Government to give us our 23-24 reduction trajectories. So we're coming to the end of Q1 now, we've still not had them. So we are tracking our performance from last year, with the exception of 2 of the gram-negative bacteremia, so E. coli and Klebsiella. We're doing fairly well, so broadly in line with last year. E. coli is probably worrying me mostly, and this is an infection that generally has a source of a urinary tract infection. And while 60% of these patients come in with an E. coli infection, we've done quite a lot of analysis of our inpatient reviews of E. coli infections, and we do have some challenges with inpatient catheter care. Now, we've just done a point prevalence audit over here in the Royal Glam, And it's probably the maintenance as opposed to insertion or removal. So we've got a focused piece of work now ongoing with the infection prevention control teams. We'll do a prevalence survey in the other sites, but we do have the highest rates of E. coli across Wales, which is concerning. But nevertheless, the majority come in, but we've still got some work to do in relation to the urinary pathway across the sites, and of course the nursing teams are on that currently. And there was nothing else in this report I wanted to pick out.
Thank you. Dom, and then Lauren, do you want to come in as well after? Or?
I was just thinking about stroke. Yeah.
Oh, sorry, I'm Dom first. Dom?
Yeah, no, the way this is being constructed is, as Greg said, we're still waiting for that national sort of report. So it has scaled down. Normally at this point, I talk about prescription errors, which actually, even though it's not in the report, there's no difference, actually slight improvement from previous times before, and mortality, which we've already talked about in the past. So the only issues I particularly want to bring up on here, but
Lauren?
Yeah, so just referring back to Linda's point about the stroke slide not being in this the dashboard this time, but work being done to address that. Some assurance that a specific stroke report went to Quality and Safety Committee this week, so there's been scrutiny there in terms of performance. So I'll give a couple of headlines if that's helpful. So there's been some All Wales funding in terms of community neuro rehab that's been stopping across all health boards in Wales. That was previously being used to fund some of our ESD service. So it's reduced the additionality from the 500,000 investment allocated this year, unfortunately. But the team has reviewed the service as a whole to ensure that it's restructured so that we can still ensure coverage across the full CTM footprint. Senior ops colleagues have established a stroke programme board, bringing together senior clinicians across stroke services. We've got recruitment underway for that additionality within the ESD service. We've talked here before previously about some challenges with people self-presenting to RGH when our specialist stroke centres are in PCH and POW, and some challenges with getting people over to RGH. So work on that is continuing, and a second ring-fenced bed has been established at PCH to try to support that swift transfer over. We've got plans for some artificial intelligence software reporting of scans to help to minimise the delays for thrombectomy, thrombolysis, and the prevention arm of the stroke programme is continuing. We run the FAST campaign locally to encourage people to seek help quickly, because we knew from the stroke equity data that we looked at that there were some delays within our population of people seeking help after stroke symptoms started. We're still facing challenges in terms of 4-hour admission to a stroke bed, but we knew that that was going to remain a challenge for us. Our consultant numbers mean that seeing a consultant within 24 hours of admission continues to be a challenge. But that's our current model and the pressures that we're facing within our services. The headlines. Thank you.
Thank you, Lauren. Okay, before we go to colleagues for questions, obviously Howell on the people part of the report.
Yeah, just a couple of things. So colleagues will be aware that there's a slightly more detailed workforce metrics report that gets a fairly good airing at People and Culture Committee. The next one of those is on the 9th, so the week after next. A couple of things just to highlight from this particular report. So you'll notice sickness remains a challenge. So we still have not seen a return to pre-COVID levels of sickness, and it's stubbornly leveled out to about the 7% mark for about the last 2 years now, which is very high for healthcare organisations. So pre-COVID benchmarking across the UK, probably 3.5 to 4%. Welsh benchmark more like 5.5%. We were sort of in the mix of that at about 5.5 to 6%. So we're running at about 1% to 1.5 percentage points higher than where we were pre-COVID. Some of the features of that are increased prevalence of respiratory illness, so cold, flu, COVID itself. Stress and anxiety remains a significant feature for us, which is unsurprising, I think, given some of the issues that we talk about, but all the same concerning and something we need to pay attention to. Couple that then with a vacancy rate, and you start to get a sense for the level of pressure in the system that our teams are experiencing. nursing and midwifery turnover is slightly starting to creep down. So I am hoping that that will turn into, over the next couple of months, a bit of a trend. So obviously we've seen that creep up to about 13%. Again, pre-COVID levels, about 8-9%. So I'm hoping that will start to come down. We are working through some measures in relation to retention. HEIW are about to produce a retention plan for Wales, which takes into consideration the long-term workforce plan that's just been published by NHS England. And we are also receiving some investment from HEIW in a post to assist us with our retention programme, which we're very grateful to them for. Just another thing that I just wanted to pick up is that the trend line improvement for Stataman training continues to be in the right direction, and has been again probably for about the last year or so. So we're up to 75% now. Target is 85, so we're getting there. We do have periodic drop-offs because you do it and then a year later it drops off a cliff. If we can just get a better system of people predicting the drop off a cliff a month before and then getting their compliance back up, we'll have cracked it. But that is a real positive. PDR, however, again remains stubbornly around about the 60% mark, which, while is better than where we were in 2020, that does mean almost a half of our staff haven't had a PDR in last year. So we really need to improve that. That's probably all I wanted to touch on.
Well, thank you very much, Jake.
Thank you. Good to see some changes in the dashboard and some more information. I appreciate that we haven't got all the targets yet. I just think back to a development event a while back where we were acknowledging that there were things that we were required to report on nationally, but that we also needed to incorporate things which showed how we're doing against what we want to do.
Yes.
So it would be good. I've got a couple of things to actually have an update on that. Within the new targets that we've been given, there are quite a number of primary care targets, which I talk about a fair amount. Good to see that they're there. I note that data is not available on most of them, but I'm sure that that will start to flow through for the next iteration. And then just focusing on CAMS, and good to hear that performance is starting to improve. Looking at the history of performance, it is quite lumpy. So we get improvements and then we get a considerable slide back. So colleagues, I would encourage you to keep an eye on that as we go forward. Those are the 3 points I wanted to make.
Thanks, Jake. Linda, do you want to come back on these points before?
Yes, our commitment to revise the report is to start in September.
Yeah, excellent. Great, thank you. Patsy.
Yeah, 4 points from me. On page 5, it talks about flu vaccine, and I know this is specifically flu vaccine in the over 65s, but at some point I think it would be helpful to understand how staff respond to getting themselves vaccinated against the flu, which obviously will help with the vacancy rates.
Yeah.
Not necessarily now, but going forward. Page 6 looks at access to dental services. I think at the last board meeting we agreed that there would be some information on the demand for dental treatment, which then puts the information that we do have into context. I think that would be helpful going forward. Disappointing, as Lauren says. I think I can use the word disappointing more than you can, that the early supported discharge for stroke has been withdrawn. Thus using quite a significant amount of the CTM investment into stroke services. I think it was 370,000, so a huge amount. And finally, I just wanted to reiterate the point on the ambulance service and the massive improvement in the handover. That was actually brought to the attention of the audit committee when discussing the annual report by the Chief Ambulance Service Commissioner yesterday. Disappointing again that doesn't correlate with the performance across Wales, across the 65% target. In fact, we're second to bottom, and the bottom one is Powys, which has geography constraints. So that's all I wanted to say.
Thank you, Patsy. Around the stroke and dental services, any comments back?
So I mean, the stroke issue, clearly that's a national, there's the policy decision being taken nationally to pull that funding back, but it is really unfortunate because it means we're now to sub basically what was funded by Welsh government. But this is part of the challenge of the current environment we're in, I guess. So we just need to, we will have a chat out there about how we might need to look a bit more creatively at some of the workforce opportunities with the wider community services integration, etc., etc. So that's all. Just wanted to pick up the point about the ambulance point, because you know, we bided our time, I think, until we had a sustained period of improvement to start to rattle a cage a bit about why isn't the red release seeing the improvement. And I think there's twofold opportunities through that. I think there's an operational link and conversation we can have with the ambulance service about that. But in terms of our commissioning role of the ambulance service, I think we might want to have a think about perhaps a conversation with Stephen Harry as the Chief Ambulance Commissioner, because if I'm being candid, you can have a conversation with us directly and you'll get the operational reasons why it is how it is. But there is something about how we as commissioners exert a bit more sort of challenge into what's the improvement plan for the red release in our patch. And it's interesting, within our patch, it varies by council area. So is it RCT seems to have the lowest rate, yet Merton and Bridgend are a bit better. And they said, well, why? What's driving that? Is that just about how the crews are allocated? Is it where their bases are? I don't know. So I think it will be something maybe out of today. And we'll talk to Gethin, but maybe we'll pick up a conversation with Steve and Harry about that topic and ask what's being done from a commissioning perspective. That's us for an improvement trajectory in the other service.
As chair, can I say I would value that, because there's a lot of pressure on health boards to improve handover times and to release ambulances from hospital forecourts. We have done our bit and we continue to do our bit. The effort of our staff has been huge in focusing an enormous amount of work in getting people out of ambulances and into our emergency departments to be cared for. On the basis that we are releasing ambulances from our forecourts, we are improving and reducing the number of lost ambulance hours. If they're not outside our hospitals, I think it is fair to ask the question, where are the ambulances if they're not picking up patients who are ill?
Yeah.
And I agreed with Gethin a couple of months ago when we were looking at the data that it was good to leave this for a few months to see what the data was telling us. But as we're now looking at this integrated dashboard report, there is a stark difference between the improvement that we are sustaining in maintaining that performance in handing over patients from ambulance to our departments and the lack of improvement, in fact, a decline in performance. If you look at the response to life-threatening calls, dipping slightly to 46.3% in June. So the position has got slightly worse. And I think it is right for the health board to ask why that is and to work with colleagues in WAST and elsewhere to understand what can be done to respond to this. So it is only therefore fair on those people who are needing an ambulance to get them to hospital that we can be assured that those ambulances are back out on the streets responding to those challenges when they arise. I'll leave it from the chair. I will leave it at the time being, but I will be following.
So we will follow up. Okay. And just a couple of other points. I mean, just to recognise the improvement trajectory in a number of areas around urgent care, obviously we just talked about, but also on the planned care recovery. I would say that I was at the leadership board on Tuesday, NHS Wales leadership board. CTM was called out, and the name check for significant improvement that's being seen now in the elective care performance. So I just think a big thank you to Gethin and his team for all the really, really hard work that's going on at a very micro level to sort of unpick sort of pathways to try and get these improvements through. And I think the team are doing some great work. And we've also just had the confirmation this week that we are going to get the regional nearly all of what we asked for the regional resources to support elective care recovery. So that will give us again further traction there, I think, which is positive. The only area I'm just going to pass a question on, and I know there's an improvement plan, but our diagnostics, particularly ultrasound, is a significant outlier when we look at the rest of Wales. And I know there's loads of work going on to do, and Sally's obviously here as well, so which is an opportunity. But I just wanted to perhaps just highlight what is happening, because there are a large volume of patients, aren't there?
I'll bring Gethin in, and then Gethin after Gethin's finished, I'll bring Ian. I think Ian's indicated as well. So Gethin first.
Yeah, so in terms of diagnostics, as Paul rightly points out, our main area of concern is about non-obstetric ultrasound, and as members of the board will be aware, when we made our investment plans for this year, it was around putting in some additional resource into the ultrasound team to help deal with that. We started the year with well over 9,000, probably close to 10,000 patients waiting over 8 weeks for a non-obstetric ultrasound. That figure now is sitting at around 7,500. So we have seen a big chunk reduction, and the profile of improvement is, I think it's around 800 patients a month will come off that backlog. So we are expecting to see that backlog reduce. Over 8 week backlog for MRI by the end of this month will hopefully just tip below 1,000 for the first time in a very long time. Our CT numbers are slightly bouncing around, but we are just over at about 1,500. So we have got that focus, but equally we know our capacity constraint in imaging is a driver of that. So there is focus. Is it all right if I just quickly pick up on dental as well?
Yeah, that'll be really actually.
So Patsy, we have got a real focus on our dental waiting list. So we have got around 12,000 patients who are on a waiting list for an NHS dentist. We have had some with all the change in the contract for dental, that has had an impact. I'm pleased to say that we have got a new 3-chaired dental practice opening in Bridgend now in October, and that will be the list for that will be allocated from our waiting list, and there is a second 3-chaired practice to open in Bridgend in Q4. So there is new capacity coming online in dental, but it remains a real focus for us. And we are now continually validating that list to make sure that only those that still require acceptance. So it is a real challenge of getting onto a dental list.
That's the new contract include things, or is it? No.
Ian.
Yeah, thanks, Chair. I've got a very specific question on Fund B, which is page 19 of 27. Looking at the graph there again. I leave ophthalmology because we talked about that before, but the orthopedics graph, the line there you can see is almost up with the ophthalmology. But what the question I've got is in the actions that are being taken. It says, what actions are we taking and when is improvement anticipated? And I think we've discussed this before, that the ongoing consultants are validating the FMB lists to try and remove people from that list. And that I thought was an ongoing situation that was taking place. I suppose my question is when are we going to see improvements in that, in terms of that graph? Apologies if somebody said that before, but I can't hear everything here.
Thanks, Ian.
Thanks, Ian. So with orthopedics, we have had some ongoing validation. What we are looking at with orthopedics is for a large proportion of those patients is to move them to patient-initiated follow-up. We know for the vast majority of these cases. So Steve Saracen, who is the Medical Director of Plan and Care, and Arwen Yorworth, who's the Clinical Director for orthopedics, both who happen to be orthopedic surgeons, are doing a big piece of work. So there's a lot of engagement around the outpatient transformation programme on this, because we think orthopedics is probably where there is the greatest opportunity for that application, and what can't give you a date at the moment, but what I suggest, Ian, is that we bring back through PPF an improvement trajectory on fund Bs in orthopedics as part of that.
Yeah, thanks.
Any other questions from colleagues on this part? No. Okay, thank you. I'm just in concluding the items, the board is resolving to note the report. I was proposing a break at this point, but I'm thinking that what we might do is just deal with 5.2 and 5.3 on the agenda, and then take a break before we move to item 6. So moving on to part 2 of the performance dashboard on the financial performance, I'll hand over to Sally as Director of Finance just to present the report for month 3. Thank you, Sally.
I'll take the report as read, but I think the things to really highlight is that month 3 showed a deterioration in terms of performance. So whilst we've held our own in months 1 and month 2 against a plan which is already, as we know, not signed off by Welsh Government of the 79.6 million deficit, that moved out at month 3 with a 2.4 million adverse variance. If you straight line that across the year, you're going to get to around 9 or 10 million adverse on the position. So that's clearly a concern, and therefore we have moved to put in place enhanced financial controls to try and address that risk. It's worth me drawing your attention to, though, that at the moment we are identifying risks to the plan of 18.5 million, offset by opportunities of only 4. So there are significant risks and some uncertainties as well. So the what happens with our energy costs as we go into the latter part of the year. We move across to the Crown Commercial Services contracts, but we still haven't got those pricing structures set out as yet. We're waiting for those. And prescribing, particularly primary care prescribing, currently we only have 1 month's data. So there is an opportunity in there that might improve. But during last year, we saw a lot of movement, particularly in short stock items, that drove up costs quite considerably. So that is a risk for us. If we look at the savings target, we are in to the quarter end undershooting on savings. Our savings sort of forecast delivery is sitting at 21.8 million, which is 5.5 million short of the target that we have set ourselves in our plan. That's obviously a concern, but we should say at 21.8 million, if we deliver that, that will be the highest level we've delivered for a very, very long time. But as we now know, the challenge is going to be even greater, because we've been asked to review our positions with a view to reducing our current forecast deficit, i.e. the 79.6, by 10, 20 or 30%, working through the impacts of that. So given the range of risks in here, that's going to be a real challenge for the organisation to work their way through that. There are some areas where we can look, or we've been told we can now consider, including ring-fenced funds, but it is a huge challenge. And to lead back to that, I just need to flag the cash position, because clearly at this point we do not have any strategic cash support for our planned deficit, on which basis we would have a cash deficit of 79.6 million. Towards the latter months of the year, we would need to put in cash control measures. So it is a very serious position we are in, and the non-agreement to our plan and now the ask to go further is going to be a real challenge for us. And we've already briefed around that, but I think it's just worth us all reflecting where we are. Happy to stop questions.
Yeah, I mean, just to back up what Sally said, we've obviously put in place some decisions around cost control, particularly relating to recruitment of non-clinical staff. And we did a briefing yesterday at the leadership forum with managers and leaders from across the organisation about the position. And it is hard. It's a very difficult message to have to give to people, but it's also about saying, if we want to try and carry on delivering and improving services with the investments we've chosen to make, we need to make sure that on the other side, that the savings are being delivered and that we are going further on our efficiency and trying to make best use of our collective resources in a different way. But it is a difficult thing to say, and I guess it's just recognising that it's another challenge that we're having to ask staff to manage, in addition to the sort of improvements in performance, the quality issues, the recruitment challenges we know are there, workforce gaps we've got across the piece. So, you know, there's something here about how we try and make sure that whilst recognising the challenging scenario we're in and getting everyone focused on achieving our financial plan, we're also highlighting some of the things we are still continuing to do positively, because there are good things that are happening across the organisation. You know, we've talked today about the performance work that's going on. We've talked about the improvement things like TPGR. That, you know, there is lots of positivity, and I think there is a balance here to strike of being really direct and open and transparent about the challenge of the finances, but also balancing that out against the things we are doing that are about improving, and hopefully things like the robot conversation we've had today show that we are making tactical investments in things that are about improving care for our patients as well.
Thanks. Patsy, Dom and Carolyn. Patsy.
Yeah, just a quick one. The adverse variance against a straight line projection. Would we expect at month 3 the savings particularly to be delivered on a straight line basis?
We have tried not to backload the savings in terms of the plan. So I think the only area where I'd say we particularly haven't accounted for anything yet is in prescribing. So we only have April data. And we at this point, while there might be some indication of some benefits, we haven't taken those at this point. So we've been finding other things to do. So we've carefully not backloaded, simply because that does create an issue as you go through the year when you suddenly go, I now can't deliver these savings. So we're bearing that in mind in terms of all of our boards. But the other thing to note is that other health boards are showing an even more significant variance based on a straight line forecast, whilst maintaining the forecast currently, which is partly what's causing some of the alarm centrally, is because there looks to be an in excess of 200 million variance if you straight lined.
And it was a 200 million variance after month 2, wasn't it?
Yes,
Yeah.
and it's gone up by
that has
another,
improved.
it's gone up by another 20.
By another 20. Right. Yeah. Dom and then Karen.
Yeah, I mean, this is, I guess I'm saying it's very serious, the position that we're in, all its excellent forward on this. I know this is the finance report, there is a quality aspect as well. We're going to have to find some way of still maintaining the services. So I suppose the reassuring bit is that we're still doing quality impact assessments when we do these, so that is in play, is still forefront in our minds. Because we have to ensure that actually we still expand, we still develop, and we still deliver the really good care that we're currently doing. So there are two sides to it, but that's not to undermine any way the seriousness of the finance situation.
Similar point really, and I fully recognise the seriousness of it and the difficulty in giving this message to staff when we're asking so much of them. But it would be really important that we hang on to the things that are making a difference to the way we deliver services, because otherwise we're stuck in this never-ending cycle of not being able to change. If we carry on doing everything the way we're doing it, quality doesn't improve and our efficiency won't improve. But that's a really, really challenging balance. I understand that, but I think it's so important that we are still implementing these improvement things and changes to the way in which we deliver services. Because we've seen, I'll talk about something in quality and safety, we've just seen where people doing that, they can make an enormous difference by providing a service in a different way. And if we can use this situation to promote that even more, I think that would be something positive that comes from.
And I think absolutely, Carolyn, in some ways, saying that never always begins crisis. And actually, there's something here about actually how can we use this as a catalyst to accelerate some of the things we know we want to make happen more quickly. So let's be honest, the fundamental challenge we have structurally is we're running lots of things across 3 sites. That is an extensive way of running services. So some of this is about how can we look quickly, and that's part of the conversations we're having at the moment about what more could we do to bring forward things. And that's very much the message we're getting from government as well, is if you've got things on the plan for next year, is any of that could be brought forward into this year that would help you deliver this. And I also think it's in the context for the conversation down about the clinical services strategy, because that is remembering one of our core goals is sustaining our future, and we are running at the moment an unsustainable model of care across all of our services from the acute side. But it also tells us why it's so important that we focus on the out of hospital care, the prevention work, the population health stuff. It's not just about dealing with today's problem, it's also about preparing ourselves so we try and sort of stem stem the financial pressure over the next few years as well. Because if we just carry on like this, we are just going to go to a downward spiral. And so we've got to also keep that in the forefront of our minds as well, about whilst focusing on hospital services and reconfiguration is important for now, the most important thing we can do is to focus on what we do outside and upstream to stem the time.
Thanks, Paul. From my perspective, can I just say, I really appreciate the amount of responsibility on Sally's shoulders, and along with her team as well. But this is a collective team effort. This is for all of us to be focused on, all of us to engage in, all of us to support, because this isn't just around what our director of finance can do. This is about where we collectively can identify how the organisation can steady itself, address the financial challenge, and attempt to contain or reduce, the likely deficit that we are facing. This is a massive challenge across the whole of the NHS. These are a series of challenges that have been many years, if not decades, in the making. And what I said to the leadership group meeting this week, along with Sally and Paul, was, whilst on the one hand we have this immediate challenge, use that word quite a lot at the moment, but this immediate challenge to respond to, we also have the ambition and the excitement and the appetite to think around what our services will look like over the next 5 to 10 years. Like, it's asking people to do two things at once in this vein is quite difficult, but it is doable. But it does mean we have to raise our heads and realise that we won't actually get to steady the ship long term and do things differently in a transformed way unless we focus on that longer term strategic agenda, which we'll be coming on to after the break. So Sally, a huge thank you to you and the team for all of the work that you are doing. But just to, if reassurance is needed, just to say again, this is very much a team effort. Are there any other questions to Sally on the detail? No. Okay. So board is happy to note the report and again to record our thanks for the enormity of the effort that is being delivered. So thank you very much. Item 5.3. The annual plan update, quarter one update. Linda.
Thank you. So this is an overview of the areas where we have made commitments to make changes in the year. What we've included in this suite of papers are the 11 ministerial measures reports that we send into Welsh Government. And I'll take those as read, and people can ask questions. Obviously, there's a lot of overlap with our performance report. But I was just going to add that in the cover paper, or at the beginning of the paper, we also list the 5 areas where we made a specific internal investment, actually for exactly the reasons that Carolyn cites. And I will, it's a bit early in the year, but I'll make sure that there's a report on those for quarter 2, 3 when we bring this back later in the year.
Questions? Patsy.
Yeah, just one. At 2.7 on the cover paper, it talks about the navigation hub. Is there any evidence yet that that is reducing conveyance?
Yes, it's a great answer, Patsy, but we can again bring, if it would be helpful to PPF, we could bring a more detailed review as it's maturing and what the expansion plans are for the navigation hub, but it is having a material impact on that element of the service.
Thank you for that. Ian?
Yeah, thanks, Chair. Just a quick question on the cover paper. This is on page 6 of 8. 2.12. Quarter 1 targets for attend anywhere have been achieved, with the exception of attend anywhere hub in my stake hospital. Do we have any update on when that will happen?
Thanks, Ian. I meant to mention that. I don't understand why we've got a fully functioning outpatients department at my stead, which is actually busier than it's been for a very long time. So I have asked Dale, who leads on the My Stead Development Force, to check in around why that is cited as a constraint, because we don't understand that. So we'll have an update for you next time. That shouldn't be a constraint. We should be able to overcome that.
Okay, thanks.
Thanks, Ian. Any other questions to Linda? No. Okay. Can I ask the board just to note the report? Thank you very much. We are going to take a slight break. Can I ask Carl if he could put the holding screen up? Thank you very much. And if our microphones can be muted, we will now break until 10:45. Thank you. Carl, can you take the screen down so we can commence part 2? Thank you very much. I welcome colleagues back to our board and move on to item 6. Just to confirm, under item 6.1, the escalation status update. Board members did receive an update on this in the Chief Exec's report under item 4.2. We'll move to item 6.2, the board assurance framework, and I'll invite Callie to present the update report, which was received by the Executive Leadership Group on the 9th of July and is before the board for approval. Callie.
Thank you, Chair. Just a couple of points to pull out of the report, which I hope is self-explanatory. Following feedback in May, we've added to the board assurance framework to include risk score trajectory. So you've got some rationale around risk assessment score and also what consideration we're taking in terms of risk treatment. You can see on this occasion that risk 1 has been suggested for de-escalation from a 20 to a 16 following the approval of the 6 goals framework and some other mitigating action that's been taken. We are currently developing a new strategic risk with Philip Daniels, our Exec Director of Public Health, around populational health and prevention and early intervention. Just for scrutiny, colleagues and board members will know that the organisational risk register is available in its entirety in admin control should you need to cross-check and cross-reference. They're the key points I want to raise, Chair, unless any board members have any comments on specific risks that I'll look to my exec colleagues to answer.
Thank you, Callie. Patsy.
Yeah, thanks, Callie. To comment on the improvements, it is really helped and it's helped the understanding, and there's been a lot of update in this period as well, which is helpful. Just one question on risk 9, sustaining our future. It talks about a climate adaptation plan. Will that be monitored through one of the committees? And that, excuse me, a follow-up question on that is the huge opportunity of the development at Llantrisant Health Park. Will that be will decarbonisation be massively taken into account with that? So, for example, solar panels on that massive roof space, which will help not only CTM but the Welsh Government targets as well.
Thanks, Linda.
Yeah, so we actually had a second way day this week and had a session on climate adaptation and agreed that our sustainability group will absorb the work of developing and deliver and overseeing the delivery of an adaptation plan, as well as so a lot of our environmental interest and activity has been around reducing carbon and reducing waste, which we'll continue to do, but it sort of became clear to us this week that all of that won't save us. We're still going to have to adapt to changes, so we need to take account of how we develop buildings, how we develop clinical care, and advice to our population to take account of likely changes that we're going to be encountering. So that's in the early stages, and of course, we're not going to kind of rebuild or move all of our. It's not one of those plans that will be short term. So it will be a case of monitoring and adapting things that we're doing accordingly. And I don't know the answer to whether we're going to cover.
Well, obviously, with the development of LHP, we will be working to try and maximise the opportunity for the site. Patsy, we've already got a lot of joint work going on with the local authority anyway. You may remember there's RCT Council developing a big solar farm quite near here, and we're looking at a wire straight from the. Sounds very technical, straight from but for the Royal Morgan site to look at the potential opportunity for the Royal Morgan to be actually entirely powered by the solar farm, and that will also, they've already said that there may be an opportunity also to look at that potential for the LHP. But obviously, as we redevelop the site and develop the space, we'll be making sure that and that will be one of the requirements of the contractors that we'll work with to help spec up the opportunity. Will be that it's as carbon neutral as possible. We have to put the market down, of course. Unfortunately, these things don't come cheap, So there is always a trade-off as well to be, you know, what you'd really like to be able to do, and then what you can afford to do. But I think within the confines of what we can afford to do, we need to be trying to make sure that we do whatever possible to have a bit of a showcase in that building of how you can do these.
Thanks, Paul. Thank you. Any other questions on the report? No. Okay. Thanks to Catherine for the report, and if I can ask board to approve the report assurance framework. Yes, that's approved. Thank you very much. So moving on to item 6.3, just to say that in respect of board committee and advisory group reports, they've been included because there are matters in the reports that required escalation to the board. So if I move on to 6.3.1 first, which is the clinical advisory group highlight, and invite Sally to provide members with an update on those items that the group wish to escalate to the board, and there'll be a chance for colleagues to ask questions once Sally's gone through it. Thank you.
Yeah, the main thing to mention is significant concern across the organisation at all levels with the delayed implementation of phase 2 of the care group structure. So hearing about the news earlier that within the next couple of weeks that the consultation will be launched, that's great. I will feed that back to the group. There's been some sort of lack of clarity within escalation pathways and where some of the specialties will sit, and so there's a sort of a feeling of unease throughout the organisation as a consequence. I think elsewhere regarding well-being of staff, there was certainly a keenness to allow staff time off in order for them to access well-being services, for example, within their working day, but realising with service pressures that can be quite difficult. But also it was mentioned as well the good working pharmacy around wellness and the joy at work sessions. And so you've been to one, and I'm going to the next one as well, and sort of try and we can distribute that further across the organisation. And I think there's a real appreciation that the emphasis that's being placed on the risk register, and there was a keenness within the group to have more advice on how to access and use the risk register and the data system. So that's been fed back. And also we're going to sort of follow within the rounds of the board meetings with a positive story as well, and we're going to have that within each of the meetings going forward, and there's a keenness again to develop patient stories, because that will help if that's disseminated throughout the various departments, because as we said, there's often bad news, but it's good to emphasise good news. So I've linked in as well and fed back to the group as to how to access sort of training for that. One other thing is the palliative care service within Princess of Wales, and I think they've reached the level where, or a state where they're unable to continue with their staffing levels, trying to maintain all of the services, and they're trying to ration what they've got for greatest impact, and as a consequence they are reducing the face-to-face service of 6 days a week, and they're going to withdraw some of the input from the hospital site in Princess of Wales. But that's more to concentrate on the community, within the thought that the patients in hospital are already seeing clinicians, and actually more emphasis should be placed on the community setting, but to bear in mind as well that telephone advice remains 24/7. I'll stop there.
Thank you, Sally. Okay, appreciate the report. Paul?
No, I mean, look, Sally's just highlighted clearly it's challenge of well-being and supporting staff at a time when there's so much work coming through the doors and people being asked to do more. It's really important that the encouragement is to try, if there are particular pressure points with certain areas where that's becoming access things, I guess we just need to pick up with those individual teams and understand what's driving that, and is there anything we can do to try and, is it taking a service to the people rather than trying to get them tracked? I don't know how much.
Yeah, I mean, so thanks for feeding that back, and I'll feed that back to the team as well. I guess part of the issue is getting to a slightly more systemic approach to wellbeing support anyway. So I think because we've set up a range of services, the reliance has become on those services, and we've got a small team of 6 or 7 people supporting 12,500. what we need to do is equip leaders and managers and colleagues with systemic wellbeing skills so that we can do some of that support more locally as well. So we're looking at that over the next little while, and that's kind of the next evolution. I think we've got a board development session coming up in the next couple of months on our wellbeing offer more generally, and just trying to move into the systemic space a little more. So keep you posted on that, and hopefully perhaps we can come along to the CAG and talk to them about that as well. That'd be helpful.
Yeah, that would definitely be welcome.
Great, lovely, thank you.
Thanks, Sal. I don't know if there's any other responses to the points that Sally has raised, or any questions from board members in respect to those matters. Okay. Thank you, Sally, for the report, and just to say that we'll note the update that's been provided, but thank you very much indeed. If I can move on to item 6.3.2, Digital and Data Committee highlights report, and Ian, I know there's an update that you wish to provide to members.
Yes, thanks, Chair. Two items I'll bring out to this report. The first one is in our last Digital and Data Committee, a number of papers that came to the committee. We spotted that there was a recurring theme taking place there, and pretty much everyone in the committee wished to escalate this up to board level, and that was that there was insufficient capacity, skills and resources within the digital and data function in order to deliver the digital and data work programme. So we wish to make board aware of that, and of immediate concern was the Information Commissioner's Office Action Plan, because the review for that is due this month. I'm not sure if we've had that yet. Maybe Stuart can update us on that. So that was that was of immediate concern. So we wish to make the board aware of that. The second item was a positive escalation, and members might be aware of a DHCW who've been developing through a programme called the DSPP programme for quite a while now, which is the NHS Wales app, and this will become available to all patients within Wales fairly shortly. So we had an excellent presentation from DHCW on that, highlighting what that app actually did. And really, we felt that all board members would benefit from that presentation, because really it does a lot more than we might think. It's based on the NHS England app, but it goes way beyond that in terms of its functionality and what it offers to our patients, particularly in the population health arena. So we felt that was a positive thing to escalate to the board.
Thanks, Ian. Stuart?
Yeah, no, thank you, Chair, and thanks, Ian. Just in terms of your first escalation around the resource, and then, so I think it's well documented, and my colleagues will be aware of. I will draw us back to at the start of the year in terms of our plan. We have put some money and resources aside. Those are still protected within the plan. I've been working with Sally on those, so we are and then relating that specifically to the ICO action plan. We were successful in appointing the head of IG after 4 recruitment rounds, so that really delighted with that. And the colleague will start with us in early September. In fairness, they are providing some support from a distance already to myself, which is really great.
It's also helpful to highlight that they used to be our
they used to be
IG,
yeah,
so
they
wait
did.
for a while, and come back.
And as part of that money that we allocated for this year, we are protecting money around information governance and cyber security. So those posts are now we've got a new structure proposed, and we're starting the recruitment process for some of those posts to give us that additional capacity that will address the ICO action plan. We will need a little bit more time. I have had the review with the ICO. It was, as preempted, it was quite challenging review. We are awaiting their feedback following that. We haven't had anything back formally from them yet. I strongly suspect they will not be closing out the action plan, which is where we thought we would be, but we'll see what they come back with on that.
Good. Any questions from colleagues to Stuart or Ian? No? Okay, thank you very much. Thank you, Ian, much appreciated, and the board resolves to note the update provided, so thank you. Item 6.3.3, the Quality and Safety Committee highlights report, and Caroline or Jane, I wasn't sure which, because I know Caroline chaired in your absence, we're going to do a double act.
I'll do the May one.
And
and
then
hand
Karen,
the dates
let's have a
to
chat.
July.
Great, fantastic, thank you, Jane.
So the dates of the quality and safety meeting have got ever closer towards. So we're now looking at the May escalation report, which is a brief positive escalation in the area of our public health activity, celebrating that our senior nurse from the Specialist Immunization Service has been awarded a Lifetime Achievement Award for the vaccination-related initiatives, which is a really important plank of our work. So congratulations.
Wonderful.
And over to Karen.
Thank you, Karen.
So the Quality and Safety Committee met on Tuesday, so just some highlights from that. In terms of escalation, we've already mentioned that we discussed the cruise mortality data and that review is underway. Ophthalmology, we focused on the macular disease follow-up not booked for patients, and that was a matter of concern that we discussed around that. The GP assessment unit at Prince Charles Hospital, we understand increasing numbers there leading to a review of the workforce. Howell mentioned, I think, mandatory training, and there was an issue raised about, in particular, in relation to CPR training and the availability of that. So that was discussed in some detail. We've already discussed the withdrawal of funding for neuropsychology support for stroke patients. So I think those were the main issues there. The other one that came up actually, which we need to highlight, was an endoscopy risk, and I don't know whether Getha might want to comment on this. This was raised by the Plan Care Group. And this is an issue about supplies of disinfectant, and that's clearly caused a huge issue. And I understand that's been being managed by a gold command structure and daily meetings, and has led to some cancellations. I don't know if you want to comment on that before I finish.
Okay.
Yeah, there has been a quality assurance issue with the decontamination fluids that are used with our washers. It is an issue that has affected the whole of UK and Europe, and in Wales it's affected Cwmdach Morgannwg, Hywel Dda, Betsy Cadwaladr, and Swansea Bay Health Board. So we have been working collaboratively to try and mitigate risk across the Welsh Health Boards. I am pleased to say that we have had now an increase in delivery, and that the immediate pressure has now been resolved, but for a period of time to conserve stock, so that we were able to decontaminate scopes to continue to provide an acute bleeding service. We did restrict the endoscopes we did over a period of over a few days. It probably affected around 50 patients who had their diagnostic delayed, but I'm pleased to say that we're now back to normal.
Can I just, sorry, Getha doesn't know this, but I've just had a text message to say that there's an improved supply chain, so looking at extreme results.
Thank you. And then I won't go through all the other matters of discussion, but the two positive things to highlight are obviously the de-escalation of T-Lydiard, which was discussed in some detail, and very thankful to see that. And we also had a patient story from Diagnostics and Therapy, which was from speech and language therapy, about a programme called Building Blocks for Communication Programme. And obviously we haven't got time to go into that into detail, but it was hugely impactful and inspiring. It was fantastic work which impacted on non-verbal children and their families. And it was a scheme that had been thought of by the speech and language therapists to reduce waiting times, to access. It was absolutely fantastic. So recommend that. Thank you.
Thank you, Karen. Any questions or comments from colleagues in respect of the report? No. Ask board to note the report. Thank you very much indeed. Moving on to 6.3.4, the Planning Performance and Finance Committee highlights report. In Mel's absence, I know, Karen, you chaired the meeting. Yep, so
very briefly, thank you. Just two matters to highlight from this. The positive escalation was around reinforced autoclaved aerated concrete, which is a phrase I never thought I'd use.
Say it again. Yes.
Concrete cancer, I think that's the colloquial way of saying it. So we're pleased to note that following specialist structural surveys on all of our properties, they've concluded there's no evidence of this within any of our properties, so that was hugely reassuring. As you know, that's been a problem, a widespread problem. The other thing to escalate was the month-to finance report, but I don't think there's any point in mentioning that, given that we're discussing finance in detail anyway. So those were just the two matters to highlight.
Thank you, Karen. Any questions or comments with Karen on the update? No. Thank you for the report. Again, the board resolves to note the report. If I can just move on to item 6.3.5, the last item on this section of the agenda, which is the hosted bodies audit and risk committee highlight report. And Patsy, I think you're going to be introducing this one.
Yeah, there's just one positive escalation for the board. We've already talked about it, but there's no harm saying again that CTM Health Board were the best or most improved at handing over with ambulances for an extended period of time, actually, and that was noted by all at the audit committee. We just need it now to move into improvement in performance.
Thank you, Patsy, for that. Any questions to Patsy on the report? Thank you. Okay, the board resolves to note the report. Thank you. Item 6.4, the annual report and the accounts for 2022 to 2023. First item, which is 6.4.1, the annual report and the accounts, the unified report. I'll ask Kelly and Sally to present the annual report and accounts. They were received and endorsed by the Audit and Risk Committee yesterday, the 26th of July, and is therefore before the board for approval. And just to say, in terms of handling of this item, just to point out to colleagues that prior to asking the board to consider the recommendations that are listed on the agenda, we'll consider all of the items in this section, and in particular the audit opinion that Mark Jones is going to present under item 6.4.3. So, Sally, sorry, Callie.
We're right, designed to go ahead. Thank you. So I won't go into too much detail. I think board members have received the annual report in detail through a number of forums. But as you said, it was endorsed and approved at the Audit and Risk Committee yesterday. We also received the Head of Internal Audit opinion, which provided a reasonable assurance. So that was also considered at Audit and Risk Committee. The report has been signed off by Audit Wales and internal audit colleagues, and any comments that have been raised through our engagement and consultation have been incorporated. Just like to thank colleagues for their cooperation in putting it together. It's a huge task every year, and particularly Wendy, who retired at the end of June, having put significant effort into that. So following today, if approval is sought, it will be sent in to Audit Wales by the end of today, and then signed by the Auditor General and laid in the Senate either Friday or Monday. So that's all I was going to pick up in terms of the annual report, and I'll hand to Sally regarding the accounts.
Sally.
A couple of these issues I'm sure Mark will cover as well. So draft accounts were submitted in time, and they've been, both the draft account and then the final version were reviewed by Audit Committee yesterday. The things to just draw out is that we did not meet our statutory duty of remaining within our revenue resource limit over the 3-year period, which is an overspend of 24.5 million, which is the result of last year's performance, and that we were unable to approve a balanced plan, and therefore we didn't. That plan was not approved by the Welsh Government. So those that the Auditor General for Wales has given a qualified opinion on regularity within the audit certificate based on those facts, and reported to the Senate that the Health Board has failed to meet the duty of having an approved 3-year IMTP. So Audit Committee have reviewed in detail just two other issues to bring to your attention. At the time we submitted the draft accounts, it wasn't known whether the one-off non-consolidated pay award that related to 22-23 was going to require an adjustment to the accounts. It was confirmed during the audit that that did not require adjusting, but instead there's a narrative disclosure within note 29 of the accounts. That was considerable relief that it didn't require a complete review of them. And in terms of the audit process went well. There are no material misstatements. There is one non-trivial, these are important in counting terms, but non-trivial but not material misstatement, which has remained uncorrected. That was in terms of impairment values. It would have no impact on the bottom line because we'd have had a resource limit adjustment as well, but it's been corrected in 23-24. We just wanted to draw people's attentions to that. The other corrections were required in terms of the related party note are covered off, and we will sort of consider. I think it's fair to say, Callie, it's the issue about people leaving in the year that we will now make sure that the process picks up, although it was hugely improved before process this year. So I will be asked tomorrow. Mark will now no doubt say to confirm that I'd still say that sign the same set of accounts as we signed today tomorrow, because that's when they get later before.
Thank you, Sally. Before I come back to Callie on item 6.4.2, which is the posted organisations governance statements and accounts for the last financial year, any questions to Sally or Callie on the annual report or the annual accounts? Okay, thank you.
Thank you, Chair. I don't intend to spend much time on this item. The Audit and Risk Committee considered the hosted organisations governance statements and accounts at the Audit and Risk Committee yesterday. So they're, for completeness, we've put them in your board pack, but I have nothing further to add.
Thank you very much. Under item 6.4.3, we've got the audit opinion from Mark on behalf of Audit Wales. Mark, I'll come to you next, if that's okay.
Yes, thanks, Chair. I'll keep it very short. Given Sally gave quite a thorough update there, which is great. And there was the audit and risk committee coverage yesterday, so I'll take questions ultimately. But I'll just mention that the Auditor General is due to certify the accounts tomorrow afternoon. Sally mentioned the confirmation that she has to give us tomorrow, because the audit does remain open until tomorrow. And for example, we remain alert to say any potential issues that could arise, for example, via the media, that could be quite significant and could be relevant to the 22-23 year of account. So that those kind of checks are routine checks that we do. So then the accounts would be certified tomorrow, subject to you as a board approving those accounts first and signing the relevant documentation, and then they get laid by the Senate, which would most likely be on Monday, and that laying would take place. I believe the Welsh Government tends to do a press release around the health accounts once they've all been laid. There tends to be a Welsh Government press release. So I'll stop there because it's been covered very satisfactorily by Sally and Callie. And if there are any questions, I'm happy to take those.
Thanks, Mark. Much appreciated. Any comments or questions to Mark on the audit opinion? No. Okay, thank you very much. Okay, before we move to approve, authorise and note the various aspects in respect of the annual report and the accounts, can I thank the entirety of the team effort for both the production of the annual report and the accounts. This is a Herculean effort, and it requires a huge amount of work on behalf of the organisation that we rely very heavily on Sally, Kelly and the entire teams to contribute to pulling all of us together. Appreciate there's a huge amount of work for Audit Wales as well, and I really do appreciate everyone's efforts in getting the report and the accounts into the state that they're in. So thank you very much indeed. So I'm asking the board to firstly approve the Cwm Morgannwg University Health Board annual report and accounts for 2022-23 for onward submission to Welsh Government. I see approval. Yes, I do. Thank you very much. We'll ask you to approve the letter of representation, including the ISA 260 under item 6.4.3. I see approval. Thank you. I'm asking you to authorise me as chair, Paul as chief exec, and Sally as exec director of finance to sign the relevant sections of the annual reports and accounts and the letter of representation on behalf of the health board. I see approval. Yes, I do. Thank you very much. And just for the board to note the governance statements and accounts received from the health board's hosted organisations at 6.4.2, and to note the formal presentation will be at the annual general meeting in September 2023, following which it will be published on the health board's website. Thank you very much. Thank you, Mark. Much appreciated, and thank you to colleagues once again. Moving now on to item 7. If we can just deal firstly with our strategic plan, CTM 2030, our health, our future. I'm going to ask Linda to present the report, which is for noting, and then I'll ask colleagues any particular questions based on the report. But this, I suppose, then will lead us into the item around our clinical services plan. Linda, thank you.
Thank you, Joe. Exactly that. So this is a regular update on progress against our 2030 objectives. And the first paper reminds us that we think of our objectives in 3 sections. One is how we support our communities to be resilient and healthy. One is how we develop our community services and offering and partnerships and GP integration. And the other then is about our mostly hospital-based services. So we've got a big item on hospital-based services in a minute, but this paper just provides a bit of an overview on the first 2 and some of the things that have been happening in that space, which are all positive and adding a lot of value, and we're starting to see some real traction in some of these areas. So I think particularly we've had some great sessions with community leaders where we've been talking about some of these resilient community activities. Philip and I are also working really closely together around bringing all of the projects that we jointly lead under one body called Building Healthy Communities, which will report into the Creating Health arm of our transformation programme, so that we are really maximising the interplay between the things that we're doing. And we're still at, I think it's fair to say, but there's still a few things that we're gathering in that we're finding, but it's really helpful to get that overview. The only thing I would say about the community services element is that we've referred here to Further Faster initiative, the Welsh Government initiative, and we were gearing up for receipt of funding to accelerate that programme. That doesn't appear to be forthcoming now this year, given the NHS financial position. So we are luckily we've put it on the back of the work that we're already doing in terms of developing community teams. So we'll carry on as much as we can without that injection of cash in terms of how we work, between us and social care. We've talked before about the integration agenda, and those conversations will keep going. But we are appointing, the interviews will be next month for a joint director of integration, part funded by each of the, well, it's RPB money, but it's owned by the 3 local authorities and ourselves. So that will also accelerate that work. So any questions on those 2 bits before I move into the big?
Quick question for me before I check in with colleagues. In terms of the Further Faster agenda, obviously the agenda is still very much there, but also the resource question is a particular concern. If that resource isn't forthcoming, then I do wonder, and I said this as a member of the RPB, whether there's an opportunity here for the RPB to start rethinking about some of the things that it does in order to align some of that work and some of that resource with delivering on Further Faster. And I think it will be incumbent on organisations, because we're being challenged as a health board to find more ways of becoming more efficient in how we use our resources and to address some of the challenges that Sally referred to earlier. But if collectively the health and care community is going to deliver the Further Faster agenda, then maybe the RPB needs to be thinking about what it does and how it does it.
Yeah. And then just to echo what you just said, Jonathan, I think also there is, as you said, that post being appointed to, but I think when we had I had a really positive conversation with chief executive for councils weeks ago, and we're going to set up a session in September, I think, to think, given the financial constraints we're under, but also the financial constraints the local authorities under, back to that thing about never waste a crisis, does it give us an opportunity to actually think doing something quicker in terms of integration of services, because we are all carrying overhead of delivery from a social care perspective and a health perspective, and could we do more together? And there's something about, rather than just tinkering around the edge, do we just need to almost take a blank sheet of paper and just say, what would the perfect system look like, and how do we actually work back from that? But I think, as Linda's highlighted, the challenge with this is that all sounds great, but that is a massive programme of change, and it requires capacity of people to be able to do the change process, in addition to keeping everyone doing their day jobs, dealing with the activity coming through. So I think, like all of these things with our ambitions, it is about the capacity to make the change happen. That is probably one of the biggest risks and limitations. And I guess back to the earlier point about trying to keep our agenda moving forward, we've got to just make sure that we're always thinking about how do we make sure we've just got enough capacity to deliver the long-term stuff. And that's the risk at the moment, is that the short term becomes the only focus, and we don't do stuff that will actually be a longer-term answer to the challenge.
Any questions to Linda? Patsy?
Yeah, just one on the developing resilient communities. I remember we had an action plan under the previous Director of Public Health that was really extensive and covered lots of things. I wonder if that's still live, if that's what Linda was referring to in bringing together lots of different pieces of work.
Yes. Sorry, I was trying to mute the chat. It kept pinging. That's it. You couldn't repeat that.
Yeah. And developing resilient communities.
Yeah.
Under the previous Director of Public Health, there was a significant action plan. Lots and lots of actions.
Yes, the anchor institution plan and the
population health plan.
What's the other one?
Population health plan.
There's another term as well. As anchor institution and foundation economy.
Yes.
And that's what's morphing into this.
Correct.
So that's what you were referring to when
We're putting a lot more, because I was speaking to Carolyn this week in terms of we're doing a huge amount in that space, but it's not necessarily connected, and there's not necessarily a clear point at which there's overview of it. So the idea is to bring it all under one roof, if that makes sense. And so yes, it's the name's changed and we've added to it, in short.
Okay. It's still there.
So that's I mean, sorry to labour it, but it would include employment, procurement, what we're doing in estates, partnership working, environmental, housing, wellbeing and future generations act, etc. So there's a huge amount of it. It all fits together. It doesn't at the moment. So Ian.
Yeah, thanks, Chair. Just one point, sort of a question, sort of a point. It mentions in the cover paper about the apprenticeships, and we going into the situation at the moment whereby if we're going to take advantage of apprenticeships, we need to be applying or putting our staff into these schemes pretty soon, because this is when the applications for universities take place. I'm just wondering, are we fully utilising that opportunity? A lot of apprenticeships are effectively free for us to put students into, so just sort of throwing that point out there.
Yeah, so we are, I wouldn't say fully, but we're getting there. So again, probably this time 18 months ago, we didn't have any real infrastructure around apprenticeships. We've now got an apprenticeship academy, working very closely with partners in University of South Wales and other local institutions to make sure that we're developing and growing our apprentice schemes. And we're also now tapping into some of the other local schemes that are run by some of the colleges, in particular profession areas, but we've got more to do. And I think it's an area we're continually developing in. It might be one that we can talk about in more detail at a future session as well. Thanks, Ian.
Okay.
Thanks. Jane.
This paper outlines a lot of good work that's ongoing and is important work in terms of delivering the strategy. But building on what John and Paul said around the RPB, I think what's missing for me here is a view of what we're doing with others using that available funding to help drive what we're trying to do, because we can't actually do all of this by ourselves. And I welcome the housing post, for instance, which is a great initiative. But for the board actually to understand how all this fits and how we're leveraging other resource, I think we just need a little bit more information.
I think it's a good point, Jane, and I think there's something about how does the agenda we're pursuing at the health board dovetail into the wider work of the RPB. I think part of the challenge we have at the moment is that we are in a lot of areas driving areas of work that frankly you'd normally expect RPB and or local authorities to be doing more in that space on. So you think about the engagement work we're doing, that that sits into like community development, right? So I think you're right, and I think maybe what we can do, and it'll probably come into the conversation as we get into the strategy work, is there is something about maybe looking at the stuff that's going on in the RPB and thinking how the board just gets regular sort of I don't know, every 6 months or so, just an update on the key bits of work and where they fit and interface. Because some of the stuff is very much, we talk about this challenge of some of what we're doing with the local authorities is just about the bilateral relationship between two statutory organisations that actually doesn't need to be in the RPB space, because it's just about health and social services working in a more joined up way. But there are obviously other areas that do need to give that broader bit. And I think it probably also reflects, Jay, to be honest, the slight mission creep that the RPBs have had over the years, where they've perhaps strayed into the territory of dealing with stuff that's actually just core statutory health and social services work that doesn't need to be in the RPB. And I know Jonathan now, as the vice chair of the RPB and with the new chair of the RPB, I think there's an opportunity to just redraw the boxes, if you like, to be clearer about what's organisational responsibility to get on and do, and what is the actual stuff that should be going through the RPB. So maybe we need to perhaps, as that starts to sort of filter out, we might want to bring that back into this conversation down the line. Thank you.
In terms of the apprenticeship bit, James put on the chat that the FESec was quietly playing its part here in CTM. I think, yeah, the FESec has got a huge role to play. So,
could I just make a comment? Sorry to, no, thanks, and it relates to that actually, because we're probably is remiss not to mention it when we talk about resourcing, but actually, just in the last week, one of the other local initiatives, if you like, through the University of South Wales Network 75, we've actually managed to offer 2, possibly 3 roles in the digital and data space, which is really encouraging and fantastic step forward for those people to train and gain a degree while on the job. So it's a similar sort of thing to an apprenticeships piece.
Yeah, just on that, we managed to recruit one of those into the HR team.
Yeah.
Well, so yeah, that's really good.
Yeah. That's really good. That's it. Okay. Just. Ian has just put into the chat, at the moment there are also degree and master's levels programmes available, funded entirely or partly by Welsh Government. Just worried that we don't tap into it, as this won't be the situation forever. Yeah, thanks Ian, that's really helpful.
And we've got people on the masters right now. We've got them on the first 3 cohorts for digital leadership. So
it's fantastic. Yeah. Okay, well, thank you for that. Okay, the board's resolved to note the report. Thank you very much. Item 7.2. Again, under our CTM 2030 strategy, the clinical services plan, and delighted to ask Linda to introduce this item for approval. Thank you.
Is it possible to get the slides up? So we'd quite like to run through them. I don't know if that's doable, but I'll start while somebody's trying to work that out for me. I will start on by saying that we are really coming today and bringing this to a formal kind of launch of a clinical services plan, assuming that the board approves the approach that we're suggesting here. And it's an important decision, because we are doing this because we see constraints in terms of how our services are being run. We've talked about a lot of those today, and as we've heard, we need to make some changes in order to make our services both sustainable and improvable in the future. And that we wouldn't be doing this if we didn't think there were going to be changes. And it's important that we recognise that this is this is a significant moment in terms of what could flow from the next steps from this process. So we want you to have be in a position to approve the way that we're approaching this and or comment. I'll go to the timeline slide which is number 2, because it really clearly sets out, I think, the work that we've been doing over the last 6 months or so in terms of laying the groundwork with stakeholders, internal and external, lots of meetings with staff and the public representatives to explain the fact that there will be some changes and why and what we're doing to design this process. And so we're very much in the second column, bringing this proposal here today. in terms of where it would go next, we'd expect to spend a lot of time with our staff over the next 3 months, then some more time talking to public representatives, ultimately leading to the development of a preferred option for service delivery, describing our service delivery, which would require formal consultation, something like this time next year. Obviously, a general election and COVID might adjust some of those dates, but that's broadly the context that we're talking in. And I set that out because if you're trying to make changes to health services, and particularly in terms of where they're provided, as you know, it's an area of massive public attention and potential legal scrutiny with judicial review. So essentially, we have to make sure that we're designing a process that can both get an answer that people can buy into, but also could withstand any challenge should that come later down the line. So that's the context that we have to consider, the approach that we're taking here. I'm going to ask Gethin to give you a bit of an articulation about why we're doing this. We've got some bullet points there, and just to assure you, so sorry, I'm on slide 3. We will develop a case for change booklet so that every time we get asked down the road, why are we doing this, we can refer back. But Gethin, do you want to give some of the overview?
Yeah, by all means, Linda. And I think, you know, there's some really positive drivers for change as well as some real challenges. And I think this is about embracing that new way of being able to deliver the services our population deserve and need. And so you know, clearly we know, we've discussed it through a variety of these meetings and subcommittees, the real need for us to take our services closer to our population. So there are a whole range of services that are currently delivered within the health board that we require the patient to come to an acute hospital for, that it doesn't require a patient to come to an acute hospital. Lots and lots of our long-term condition management can and should be delivered far closer to the patient in their own communities, with the associated support that patients with a range of long-term conditions have. So you know, I think that, you know, a big focus for us has to be about shifting our services where appropriate, much closer to the patient in their own community. But equally recognising that for a range of our acute services, we're ending up with 3 very small services, and they're not able to respond to the need of our population, and replicating that creates significant challenge. By bringing those services sometimes together on 2 sites, sometimes together on 1 site, allows us to create that critical mass. It allows us to put resilience in, it allows us to subspecialise and create those teams, and it also allows us to adopt new technologies. We've had the conversation about the robot this morning, and that bringing cutting edge technology into our health board. You know, sitting on the opposite side of the car park to the building we're in today, we've got the Snowdrop Centre, which has brought together for our population all our breast services. That's created a significantly greater, far more resilient breast service. It's attracted people to come and work here. We also know that we've got a real imbalance by running 3 acute hospitals. We've got a real imbalance in our workforce around their non-elective, their emergency commitments, and that of the commitments that they can provide to our elective services. So our patients wait longer for treatment than other health boards, because our doctors and nurses and AHPs and all of those teams focus a greater proportion of their time on emergency services. So if you take orthopaedics as an example, we have the same number of orthopaedic surgeons as Nara and Bevan. Their surgeons have 3 times as much elective capacity in their job plan than ours, because they run one site with an on-call, whereas we've got three on-call rotas. So that, you know, really does create a challenge. We equally can't provide our patients with the right subspecialisation. So, you know, there are across these areas where we can have 1 or 2 surgeons providing that very specialist input. We can't replicate that everywhere. So it is about, you know, needing to look at centres of excellence within services that we can provide that. And equally, we know, and we've debated at this board, a range of services where we are not able to meet the optimal pathways, the national standard pathways that we know have a material impact on the outcome of our patients. We've discussed probably at every board our challenges around delivery of a compliant stroke service. We cannot provide that within the constructs that we currently operate, and we know that has a negative impact for the outcome of our population for when they have stroke. And the final piece, and you know, you heard from Paul earlier, you know, about the pull of that change, and we're seeing it across a range of services at the moment. That our workforce fragility is such that actually we need to be having bigger teams, and we need those teams to be able to provide those services on a far more robust basis. Be that medics, be that nurses, be that therapists. We know we need to be able to do that in terms of those scales. So it's really important, I think, to give our population the quality of service that we all want and believe our population deserve. We need to do this.
So next slide, please. So in order to try and encapsulate what we're trying to achieve here, we have written a vision statement. What we're trying to say here is that this clinical services plan will improve the way that we provide NHS services, but you know, by making sure that we make best use of our resources and expertise to continue to provide safe and effective care. I think quite a lot of our clinicians would say we're just about hanging in there in terms of safe and effective care for the reasons that Gethin said, and we won't be able to continue in this way and to be future-proofing our services. So that's what that statement is trying to say. You might have comments on the way it's written. We certainly have had some comments from our clinicians, and we might end up trying to have another stab at it, but I'll see if there's any comments on that. The next slide just reminds us that it's not just about the benefits that we need to deliver are as much about carrying on the work around culture, training, support, just being good at what we do and empowering our patients and communities. And then finally, for me, we've now got a dozen or so principles, 8 or so principles by which we would need to test any suggestions that we arrive at. So clearly, I'm not going to read out the description, but just a sort of remind us that the principles are that we're patient-centred. These aren't in any particular order, by the way, that we have to cover all these bases. Patient-centred, clinically effective. There's a typo, actually, it's access and equity, not equality. Apologies for that. But that we are focused on population health. We can't say it enough. We won't be successful if we don't continue to, drive the prevention, early intervention, self-care, and care in community settings agenda. Got to be, and actually with some of the work we started to do with clinicians already, they are really keen to embrace the opportunities that a digital environment could give in terms of shifting patterns of care, and we really need to really embrace that. Obviously, we can only work with the workforce that we're going to have, and so we need to be smart about that too. And then ensuring that our services are sustainable. We're familiar with that concept, that we make best use of our best buildings, and the whole question about being integrated both locally with our partners, but also across South East Wales, and we're needing to work to align this to our neighbours. So just a quick word on site development or on options development. We're going to now do a period of work with our clinicians, getting clinical teams to say, well, you know, within our constraints, what are their red lines? What do they need to do to make to rework their services to achieve all of the above? But we're going to do that in a site agnostic way. So we won't get into we need to do this here and that there. We'll get that picture of what we need to bring together, what the interdependencies are between services, and then we'll start to work up some options, which will you know, be then tested through the above conditions. So we've got just the last comment is that in designing this process, we've tested with various Welsh Government and clients as well, seeking some peer review too, because my task, to be honest, is the process. Everybody else's task is to input the content to come up with the answer. So I'm trying to make sure that it's robust and as I say, withstands. So we've in the paper, the cover paper, Chair, we've asked people to note this process and agree the vision and the principles. It may be that we have some debate about the vision and principles, and which I think is fine. I think really what I'm asking is comment on, you know, whether we're good to proceed on the basis of the conversation.
That's really helpful. Okay, any questions or comments on the presentation, the content, the vision, the ambition? And thanks to Kevin as well for outlining. Yeah, I'll put Linda in now 2 seconds. The scale of that, because I think this is about us setting an ambitious, exciting future for this region. About saying clearly to people who want to do more for you to ensure you are accessing the best possible care and treatment and support that you need to get to improve your health outcomes. And I think we want to mobilise and enthuse people about this transformation agenda, because it is a transformation agenda, and that's what this is about change, but principally and importantly is about improving what we do. Linda?
Thanks, John. I am completely bought into this, as you know, Linda and Paul. I think this is just absolutely essential work. So thank you for moving this on since our last meeting. I think just a couple of comments and maybe sort of the questions as part of that. For me, this is, as you said, Linda, the process is like, it's really easy just to kind of sort of go, this is the process. It's actually living the process and living the engagement that's going to be the mark of success or failure, I think, to this. So I was wondering whether or not, as part of that process, the act of getting some real champions on board, because in my experience, just the chief exec chair and Ned saying this, it means one, but how can you get people to champion it? And I'm sure that's probably part of your process, and forgive me if that was in part of the presentation. But I wondered about that, including maybe patients, including, you know, community groups and people like that, because I think if other people can tell the story, then that's what you want to hear and everything. And I guess a point I made last time, and I'm sure Simon's all over this, but this is like over engagement. We can't do enough engagement on that, so providing all of us with the right messages I think is going to be really important. But just to say, I'm really supportive of this, and I think it's great to see it having evolved since the last meeting.
Thank you. Thanks, Linda. I'll just bring Simon in, and then Jim, and then Howell. Simon?
Thanks, Joe. I was just going to mention, it's worth reflecting on the conversations we had with the CTM 2030 leaders group last Friday. So we had our normal quarterly meeting with the leaders of groups who represent our communities across the entire CTM patch. And we took these principles and the challenges we're facing and the need for change to discuss with those people. And it has to be said, not a single one of them balked at the fact that there was a need for change. It was universally understood in the room, and that room did also include some staff as well. So that was really important. And it was a really good place to start that conversation, because we also asked those same people, what are going to be the things that we need to be aware of, what's going to be most important to people when we start engaging with them. You know, and that throws up some really interesting things, which aren't necessarily just about the service, the location of the service and the delivery. So it's about important things like transport infrastructure, which anyone who's ever been through any kind of consultation on service change knows is always kind of up there in the top 3 of reasons why people tend to kind of fight back against these things as well. So it's really important to say we started that conversation with community groups. They didn't balk at it, and they are happy, and they're kind of giving us some really good insight. They also said, Linda, to your point, Lots of people in that room really want to be part of supporting the engagement, being ambassadors for that engagement within their own community groups, which will be really important for us because lots of people in that room represent parts of our community which we struggle to engage with. So a really positive start, but absolutely it's as you said, it's just the start of what will be a very comprehensive programme of involvement, engagement, and ultimately consultation at some point as well.
Thanks, Simon. Linda,
Just on this same point, I think by the same token, we've got lots of clinicians that are willing to shoulder the messaging and to, you know, be part of, be advocates. Yeah, well, obviously, presuming that, you know, the process works and they understand what we're saying, but they are very keen. Yeah.
Thanks. Jim, and then Harold.
Thank you, Chair. I'm sort of mindful of this is a sort of a public broadcast. I'm just keen to say I fully support this approach. This initiative is really welcome, and I think that it's also encouraging for the public to know that their lived experiences, either patients and the communities, have actually helped in the engagement. You think in terms of my stay, I think of the improvements with our maternity and neonate services, and also the work done and ongoing at St Lydia. It just shows how we can bring people in, and they will be our ambassadors going forward because they will feel part of the way forward. And I endorse the comments my colleagues have made as well. Thank you.
Thanks, Jim. Harold?
Thank you. So Linda, you alluded to the vision thing, and every time you show that to somebody, you'll have somebody trying to reword it. I know that, so apologies. I just wonder if there's a little way just to describe the aspiration for our people in there, and I can think of a way to do that. So happy to work with you on that, because we talk a lot about optimism and hope, don't we? And there's quite a bit of that in this, and some real opportunities to improve conditions for our people as well as population. It does it a little bit in the principles, but I just wonder if we can just have just a brief couple of words without completely messing up the vision.
Paul? Yeah, that's it. So I think this is a really important step forward for us as an organisation, because, you know, ever since I've arrived in the organisation, everyone said, well, we know we need to know where we're going, we need to know what the future holds, and in some ways the workforce challenges, the demand challenges have just shown, haven't they, that needs to be accelerated because of the pressures that we're all facing. I guess there's a couple of things here, and of course this element of it, as Linda described, is one part of the conversation about it, because it isn't just about the acute hospital side. And whilst it is about the acute hospital side, I just don't want to lose the opportunity to constantly challenge why we do this in a hospital in the first place. You know, because there's a real danger that we go into it with a view of, well, we'll take the hospital services and remodel them within hospital 4 walls, and we just move them from one hospital to another hospital. Well, actually, I want to ask the question about, well, why are we even doing it in a hospital in the first place? And actually, more importantly, why isn't the patient doing it for themselves using technology? Because actually, if you started at that point, suddenly the bit you keep in the hospital is, dare I say, less cumbersome and less of scale, that enables you to be more fleet of foot and do it. So I think, and I know Linda knows that, but I just think it's really important to say and set the parameters, which is why in the principles it's so important to say, I'd say we need to perhaps add something in that only in a hospital if it can only be done there, sort of thing. And that's one point. Second point was, the other thing we've got to remember in this is there are lots of people out there who will tell us all the reasons why everything does need to be done in the hospital, and why it needs 45 consultants to deliver a service. And I'm just thinking, you know, we need to be prepared to how we're going to respond, because, you know, Sally will know, and others, you know, there are royal colleges out there with guidelines that say to deliver a service in A, B or C, you've got to have, you know, this many consultants, this many middle grades, this many trainees, this many, frankly, which is unaffordable. They're not out there, realistic. So I just think we need to prepare ourselves. And one of the things I'm just thinking, Linda, is we had Yet and I had a very positive conversation with the Royal College of Surgeons recently in Wales about Llandryston Health Park. They were really keen to support us in helping facilitate conversations with our clinicians about how these sorts of models of care need to change. And I'm just wondering, alongside our internal work, whether we don't need to perhaps form some sort of advisory group of people like Royal Colleges, digital technology people who we can probably perhaps test things with, and perhaps field in conversations with clinicians to sort of just prompt thinking and challenge thinking, because I think it would be really positive to show, bring in external people who might lift people's eyes a bit and say, we can do that differently. Other people have done, and signposting perhaps, so that's one point. And final thing, say the political engagement. I know John and I have already started just sensitively trailing with MSs, MPs, local council leaders and others, the changes that are probably going to be coming down the track. And I have to say, universally, a bit like with our community groups, everyone said, if we're involved early doors, if we understand the rationale and why you're doing this, we know that things are going to have to change, because, you know, part of the challenge everyone reads about on a daily basis about the NHS, isn't it? Everyone knows it, which in some ways is an advantage now, because the scene setting is almost being done by all the media nationally. So I think we will get there. I'm not a naive to think there won't be some bumps in the road, but I think the place we start from, because of the groundwork that's been done, and I know it perhaps has felt that it's taken quite a long time to get us to this place, but I'd rather spend that time putting in that groundwork so that when we do start to make change, we've got a better chance of success. But I do think, you know, this is a really positive step forward for us as an organisation, and gives us a good platform to start with.
Patsy, Dom and Karen.
Yeah, just how's paved the way to make a comment on the visions. Just right at the end, it talks about the needs of all our communities in the future. Should it be now and in the future? Because earlier on it talks about continuing. So continuing is now. So
can it's really helpful, and I think perhaps what we could do is, if there are suggestions, take it offline. I think, you know, I'm always aware that, you know, a camel was a horse designed by a committee. And I think we could spend 3 hours working through each word of the vision statement. I've used transformation a couple of times, so I'm not suggesting it has to be in there, but there is a risk we spend a lot of time. But the good thing is, I think the vision is captured really well. I think there's probably a couple of changes to be made. That's terrific. But yeah, but thank you for the suggestion, Patsy. And I'm sure there'll be others probably flowing into Linda's inbox at the end of the discussion. John and then Karen.
Yeah, my comments would be back in such a brush, of course, comments there. It's like, you know, the question of why in hospital should be our that's the first point. I think there's an anxiety straight away then primary care are going to go, hang on, I used just we have to pick up all the work on that. And so that there's a reassuring point here that actually this primary secondary care interface work is going on very strongly, and it's not about primary care and GPs picking up all of that activity. This is about acute team working in the community and spreading out in as well. So there's a huge amount of work going into that at the moment, and we'll expand.
Before I bring Karen in on this, can I just say, in terms of that shift of things from secondary care out into the community, I'm afraid that is a given. Yeah. That will happen. It is a ministerial direction. You know, the policy view of Welsh Government is that we need to be doing more outside of our hospital environment. There's been a huge presumption of the growth of hospital-based services over the last 75 years for very good reasons. But we know, because talking to our care groups will tell us that why this is the case, that more of this stuff can be done out in the community. I think working with our clinicians who've got all that expertise, I've had some really interesting conversations the last month or so. People said, look, we can do this out and about. We don't need to be based in a hospital site to do it. And I think having the clinicians to help lead that conversation, going back to Linda's point, is absolutely the right thing. And I've met so many who are really geared up for, and quite excited by being able to lead this. And I think it is around leadership. And I know we've got the capacity there amongst our clinicians to do it. Carolyn.
Yeah, just very briefly, fully supportive of all of this. Can we just make sure, and I'm sure we will, that we're not totally focused on a medical model, because we are seeing in lots of areas, we can't get those people anyway, but the value of all the other AHPs, all the other health professionals. So just to make sure we don't have too much of a focus on the solely medical model.
Absolutely. Thanks, Carolyn. Dennis.
Yeah, I was just going to say that we need to consider the people that we meet in the leadership forums and what they can do to assist us, because there's lots of third sector and voluntary sector organisations out there who could make this job a lot easier for us, and make sure that we include them.
Yeah, absolutely. But no, just exactly on that, and it'd be good to have them involved in terms of looking at what outputs and metrics are as well, having those identified by ultimate users.
And Ian. Sorry, Ian.
Yeah, thanks, Jonathan. Just a quick comment. Yeah, I'm fully supportive of this as well. I just echo what other people have been saying. So something that we really need, I think, in order to take things forward. Just a couple of points. And I think we probably go into the most important phase of this at the moment, and that's the engagement process. And other people have commented on this as well, in terms of engagement, not just with our staff, but with the community and so on. But I think how we do that is absolutely critical. If we just engage with local organisations, we'll miss the bulk of the population. I know it's hard, but what we did in my stake hospital, that I think is a model, and we've done this in this area, and I think we really got into the community with that. And I think that level of engagement throughout this process is essential. Whatever we do, to be honest, we'll have critics, and people will say, "Oh, we shouldn't have done that. We didn't want to go that way." But I think we need to sort of try and do as much of that engagement process as possible. In universities, we used the term co-design, and that was when we designed processes with the students in the university. So we're sort of designing things with the community and bringing them along. People can't then say we weren't consulted. So I think it's really important, that process, and comms really important, I think, throughout this period. Thanks.
Thank you, Ian. Paul?
Yeah, just to comment on that, and I think you're right, and I think there's both and, isn't there? Because what was really interesting at the session we had last Friday, where we had a number of voluntary groups, was the message was very clear. If there's something that you need to do for the reasons of safety and quality, just say that and be honest about it. Because they said there's no point talking to us about something if no matter what we say, it's not going to solve the quality and safety problem. So they said, be honest about the things that you can't change. You've got to make it, you've got to make it because of the safety issues. And then let's talk about the things that are perhaps the areas where there is some discussion to be had. So it's a really important point. I think the model from my stake does give us a good opportunity. But I also think, and again, this came over really clearly from the session last week, was the message from people saying, often in our communities, people will listen more and trust more what a colleague or somebody in their community says about something than any of us around the table turning up in town telling them this is what's going to happen. So I think it's about having some of those strategic conversations, but there's also the positive thing we had last Friday was people saying, we give us the messages and we'll go out and talk to our communities about this. And I think there's a real art to how we're going to do this engagement for this process, and it's going to take some careful crafting and thinking. But I do think we have the bedrock and we have the trust, frankly, with some of these community groups now that we can go and have quite difficult conversations about things, and they'll understand why we're trying to do it. So, I mean, of course, there's going to be problems, of course, there's going to be issues, but I think, as I said earlier, we've got a good bedrock to work from.
Linda?
And actually, we genuinely don't know what the answer is.
No.
So we're not pretending that this is, so that was a reassurance we were able to give on Friday as well. So because some of us have got ideas, but they're different, and we do, and including our clinicians got ideas, but they're different. We do need to go through a process, due diligent process to arrive at something that we can all live with. And by the way, much of our benefit, as you say, will be from standardizing processes, working to best protocols, getting all the good work that's carrying on. A lot of benefits will come from that. We're only going to move something if we really need to, and everybody can understand that that's the best, the best outcome.
Thanks, Linda. And it goes back in some respect to Dilys's point around the third sector organisations. We've done a huge amount of work in developing that CTM 2030 leaders group. People have been really engaged in conversations, and I think it's not just about us asking them for things, but us demonstrating to them that we can share the vision, that we can share the ambition, and to engage them right at the outset. And we're very lucky in this region. We've got a huge number of very locally based organisations with great reach, and I think that relationship is of mutual benefit.
Very, very quick points. It's probably something we get involved in directly, actually. And we've got the leadership groups, got people there, but actually it's our advisory group to us, and actually.
And before I ask you to approve the direction of travel, in particular the draft vision, subject to one or two perhaps words being altered, but also the timeline that's been set out, that's really important, and that will give people a sense of what it is we're trying to do and the purposeful way in which we're trying to do it. Can I just thank Linda, Gethin and the entire team really for what has been a big piece of work so far. I know a lot of engagement has taken place with a variety of different parts of our organisation, with our staff, with our community groups, with our stakeholders in local government, national government, and those who represent the region in the Senedd. That process will continue now when we share this information with our colleagues and start building that conversation out. So my thanks to all who've been so actively involved in this. Can I ask the board firstly just to note the update, but also to approve the draft vision subject to any tweaking of words, but also to approve the draft principles, and in particular the timeline that's been set to deliver what is an ambitious but a very exciting transformation of our services. Thank you all very much. So approved. Thank you.
Thank you.
Thank you, Linda.
And so, Jonathan, just to say, is on the basis of that, we will now write a briefing today, tomorrow, to some of the sort of key politicians to let them know that we've made that decision, and think about the internal comms as well, so that people are clear what's been decided and what's happening next. So,
thank you very much. Really appreciate it. Thank you. Okay, item 7.3, working in partnership. Just to say, this has been covered off, I think, in the various committee chair reports and hosted body and partner organisations. So it's just for noting. So I don't think there's anything specific colleagues need to raise under this. No, thank you very much. Item 8, the consent agenda. So if I could ask board to approve those items listed from 8.1.1 down to 8.1.4 as a block. The board happy to approve those items on the consent agenda. Thank you very much. And again, those items for noting, if the board can resolve to note those items that are listed 8.2.1 to 8.2.5. Yes, thank you very much. Item 9.1, no other business has been raised with me as chair. However, there is something I wish to say about our vice chair. But it's not Jane's final meeting, because Jane's final meeting with us as a board will be the board development session in August. However, this is Jane's final board meeting in public. And I just wanted to say a huge thank you on behalf of the entire organisation to Jane for the 8 years as an independent member and vice chair, for the contribution she has made to this organisation across the 8 years, for the enormity of the work that she has done as vice chair, particularly around those areas of primary care and mental health services, amongst others. And can I say, as chair for only the past 4 months, how much I valued your advice and your support since I became chair of this organisation. I know you are going to be sorely missed by all of us. You've made a huge contribution, and I want to wish you well in your new role as an independent member at HEIW. Our loss is certainly their gain. I think you will enjoy the role. It's a really important organisation strategically in terms of our workforce planning and education and training, and I know you'll have a superb time there as an independent member and make a big contribution to that organisation as well. So Jane, thank you very much on behalf of all of us. The thanks will continue over the next month, of course, until the final meeting that we have as a board at the end of August. But I just wanted to put that on record in public session. Thank you very much, Jane.
Thank you. May I respond briefly in public session? It's been an interesting 8 years, and we've been through some difficult times. And it's actually been a real pleasure to work with colleagues, board member colleagues, and executives over time, and particularly this executive team, which has really gelled as a team under Paul's leadership. I leave board confident that it's much better governed, that the quality and safety agenda is firmly in the board's sights, supported by very effective financial management, even in challenging times. And I'm confident that this board will continue to develop and deliver for our communities. And I leave pleased to have that confidence, because I wouldn't have always have had it.
Thank you, James. Thank you very much. Indeed. Thank you. Just by way of some housekeeping, as per usual with our meetings, in asking how did we do in this meeting, I'd ask colleagues just to refer to the questions that are listed on our board papers and to forward any comments for improvement at this point, or perhaps within the next 2 weeks, but perhaps I should suggest the next 2 weeks. Just to remind colleagues that there is an in-committee session of the board following this meeting. I think it's due to start at 12:30 to consider 2 items: the implementation of robotic surgery, the business case that will be before the board, and also laboratory information management contract extension. That's the second item that will be on the in-committee board session later this morning, or rather early this afternoon. Just to confirm, the next meeting of the public board will be on Thursday, the 28th of September, commencing at 10 a.m. However, there is a board development session on Thursday, the 24th of August. Rydw i'n dod i gyfarfod y bodd iechyd ben, a hofyn y diolch y bawb sydd wedi ymuno yn ei gwylio gyfarfod heddiw. Now bring the board meeting to a close. I'd like to extend my thanks to all those who participated in the meeting and to those who observed our proceedings today. Thank you all very much indeed. We are done. Thank you. Thank you.